Our planet never ceases to amaze us. The best is always waiting to be discovered. Every corner hides unseen treasures. In unknown places, treasures of breathtaking beauty that leave you spellbound. Where you can reach new heights and feel on top of the world. Run your fingers along the relics of a rich past. Discover new places where you can leave your mark. Be the first to witness a land of fascinating journeys. Where in the world could this be? Saudi. Welcome to Arabia. Get your visa now.
COVID-19 has challenged the capabilities of healthcare systems around the world. The virus shows little indication of slowing down. So digital health innovation has become even more imperative. The pandemic has accelerated demand for technological solutions. Tracking, monitoring and predicting coronavirus outbreaks. Innovations save lives. Through telemedicine, analysing health data and robotic patient care, all while artificial intelligence plays a vital role in developing drugs and vaccines. We must build upon this momentum and achieve unprecedented advancements in digital health. We must advocate for digital health solutions as a core part of countries' recovery plans. Global collaboration is our best chance for success. Hosted by the Kingdom of Saudi Arabia as part of International Conferences Programme, honouring Saudi's G20 Presidency year. The Riyadh Global Digital Health Summit is bringing together leaders, decision makers and pioneers with the ambition to realise the greatest opportunities of this century. Join us as we create the Riyadh Declaration on the role of digital health, an actionable roadmap to enable the international healthcare systems to jointly contend with global pandemics, one of the most pressing challenges of our time.
Ladies and gentlemen, welcome back to day 2 of the Riyadh Global Digital Health Summit. Thank you for joining us. We have an exciting program for today, but before we start our sessions, a quick reminder to our audience. On the right side of your screen, you'll find the Q&A panel. You have the opportunity to engage through posting questions and voting on polling questions. These interactions will take place at different times during the event, mainly before each session. So don't worry about the technical side, we will guide you through it. To kick off the day, would like to hear first from you, the audience. So on your screen, you'll see a polling question appear. The question is, on a scale from 1 to 5, how strongly are you satisfied with the current technology's abilities to enhance public health awareness during the COVID-19 pandemic? 1, strongly dissatisfied. 2, dissatisfied. 3, neutral. 4, satisfied. And 5, strongly satisfied. You have 30 seconds to answer. We're going to show the results in a bit. So as we see, the majority chose or they are satisfied with the current technology's ability to enhance public health awareness during the COVID-19 pandemic. Interesting. So our first session of the day will be diving into the topic of digital public health. And to do so, it's my pleasure to introduce the Medical Director of Public Health Scotland, the National Clinical Data and Digital Lead at the Royal College of Physicians of Edinburgh, and the Honorary Professor of Health Intelligence and Service Effectiveness at the University of Glasgow, Professor Mahmoud Adil. Welcome, Professor.
Thank you. Thank you. Can you hear me first? I trust you can hear me. Let me say that good morning, good afternoon, good evening, assalamu alaikum, wherever you are and you're listening to this conference. I'm sure all those over 100,000 people in 110 countries who have registered, I'm sure many of them are tuned in. And I congratulate the Kingdom of Saudi Arabia and G20 for providing this excellent platform to take this particular agenda forward. So let me talk briefly about the subject given to me today. So I'm honored to chair this session, which is we've got two very, very good and eminent speakers. But let's talk about the subject first, digital public health. So the Charles Edward Winslow, the Dean of the Yale School of Public Health, gave the first comprehensive definition of public health in 1920. It was subsequently adopted by WHO in 1988, defining it as the art and science of preventing disease, prolonging life, and promoting health through the organized effort of the society. In the light of the development of data and digital science, time has come that we have to revisit this definition. I would propose to improvise this definition by saying the art and science of preventing disease, prolonging life, and promoting health through the organized effort of society and with appropriate use of data and digital intervention. We should aim that digital elements should become part and parcel of public health, so that we do not need to specify digital public health. Rather, public health means that data and digital is already part and parcel of it, and it won't be complete without it. Again, this summit is a great opportunity to take this idea forward. With this brief background, I would like to move on to the main session. So we have got two speakers. The way this session will pan out, they are going to speak in their turns, 20 minutes each, and I trust that they will stick to their time. Subsequently, we will have question and answer session, and I will encourage all the listeners and viewers that they should put forward their questions. Of course, I can't guarantee that all of their questions will get answered, and then at the end, I will take 5 minutes to give my personal reflection, and I will summarize the session. Okay, so without further ado, let me introduce our first speaker, Dr. Q. Reed. He's a Vice President and Chief Health Officer at IBM Corporation and IBM Watson Health in United States. And he's going to take the floor and he's going to give his first presentation. Over to you, Dr. Reed.
Thank you, and thanks to everyone all across the world and the work that you're doing personally, for your families, professionally during this this pandemic. Brene Brown talked about the pandemic in a way that was a global vulnerability moment, and I would suggest this is a unique time for us to look at what we value as a society, as a global community, and how we can improve and address many of the issues that are now becoming more and more visible that we need to consider as we think about digital public health. We're more globally connected than ever. We're more globally fragile than ever. I remind myself as I woke up this morning on the East Coast of the US, why I work so hard as I kissed my two daughters and my wife coming down for this presentation. And so I think in many ways we're reminded of how hard we work and how fortunate we are, many of us, like myself, to have the ability to work from home, for example. So what I wanted to talk about here is, in many ways, this global vulnerability moment, this visibility moment, especially as you think about the role of big data and digital public health. And I would also suggest the way in which each of us in our companies, in our organizations, in our settings, can reflect not only personally, but as within our families, within our communities, within our work communities, how we can maneuver and address this crisis. And once again, address these items that are becoming so much more visible. And many of these items are very data-driven. And data is such an essential component of being able to make good decisions. And so I wanted to briefly talk about how IBM, with 350,000 employees, over 170 countries, I mean, if there's a global community that I've been fortunate to be a part of nearly the past decade, it's IBM. And as we reflected and we reflect on how we responded to this crisis, we thought about our own employees first, the area of resiliency and adaptation. We do think that this new normal that is evolving will require a workforce that recognizes the need to adapt, to embrace digital capabilities and technologies. And whether it was from Wuhan to Wilmington, we acted as it relates to the safety and health of our own employees and our workforce. And so 95% of the IBM workforce now works from home, and 5%, many of whom are essential workers who support data centers that support our financial systems or broader health systems across the globe, are working in this crisis and really looking through evidence-based methods to really provide that health and safety that's so essential as you think about the social contract between an employer and an employee and the importance of trust. Which brings me to the area of trusted information and how essential it is at a time like this to lead with science, to leverage science and scientific experts and clinical experts and public health experts. And so leveraging AI in over 25 countries now, in terms of what we've gifted in terms of Watson Assistant to provide solutions that leverage evidence-based sources so that when people are looking at information about COVID, they're getting the most trusted and accurate information for their community. And we've done that through the Weather Channel, which has about 500 million users globally. And we've provided that access to that information about your cases in your community, but also to trusted sites and also links to the Red Cross, to clinical trials, to volunteerism, this recognition that, health is very local and providing trusted information is essential, but also helping support people to act is also important and activate. And then accelerating discovery. We recognize that the supercomputers, the world community grid that we have also can support the acceleration of discovery. I think we all recognize that our capacity to learn, our capacity to maintain knowledge typically could be supported by computers that look for information, look for that needle in the haystack, look for that mutation or that unique new study that you don't have the capacity to maintain in your own mind. So the use of supercomputers to accelerate discovery and research for doctors and scientists to address this COVID-19 pandemic, whether it's drugs that need to be repurposed or vaccines that need to be discovered, is another key component of our response. And so as we reflect and we continue to restlessly reinvent ourselves and think about the needs of the global community, our clients and our partners, we consider the importance of security. While we're talking about technology and digital, I would say the most essential ingredient in health and healthcare and public health is trust. It's fundamentally about the relationships and how technology is used to facilitate the trust that's so foundational and fundamental in those relationships. And so whether it's cybersecurity, whether it's business continuity, whether it's data that needs to be secure through the cloud or through a hybrid cloud, we all are now challenged with a new normal of, some roles. Can you work from home? Can you sell from home? Can you learn from home? And so in many ways, in the same way that my daughters have challenged me to share more of myself with their pictures behind me, I think there's a vulnerability moment for us where we're learning more and more about what can be done at home versus what could be done at a work site or a workplace. And so making sure when you go to that workplace, you're safe and you work smart is really essential as well. So another area that we've worked very hard on as a company, as we think about our role, and the recognition that all companies are health companies. I think the pandemic has recognized this, and all organizations are health organizations. And so I think many of us are familiar with the curves. It's extraordinary how IBM has been around about 110 years. The last global pandemic in 1918 was 102 years, but we all have gotten what I would call literacy in public health, the idea of these curves, whether it's cases, hospitalizations, deaths, and the need for us to work together across an ecosystem to help flatten the curve and bring things back to normal. And then this challenge of health and economy and privacy, the balancing act of this, what we call a trilemma across so many topics and issues. So this highlights, of course, as we recognize there's so many curves that need to be flattened in COVID-19 and in each community, in each country. But as we reflect more broadly, as we're looking at the big data, as we're talking to clients and partners, as we're thinking and recognizing the broader issues that exist in public health, we recognize there are 4 curves that need to be flattened. In addition to the infectious disease curve, which of course COVID-19 has helped us recognize, and you can't forget about things like the flu. But you've got now this challenge where mental illness is becoming much more prevalent, higher incidences as we're socially isolated, as we're more depressed and anxious. We're also seeing that many people are delaying care, their chronic disease care, their mammograms, their colonoscopies, their preventive services, their vaccinations, as you look at the big data. So the challenge then is, what is happening is these diseases are getting worse. You could have a cancer that could have been treatable become a metastatic breast cancer. You have, a heart disease situation that's more treatable that could become a major heart attack. So we've got challenges in the chronic disease curve. We've also got inequities. I think this global visibility moment is making us recognize how fragile we are as a society. How communities of color and poverty and indigenous populations are often the more significant victims, more vulnerable victims, the elderly of this virus. And it does challenge us in terms of what we value and what we must do to flatten the 4 curves of COVID. So as you reflect on the opportunity here, this slide, in my mind, represents really the essential on the right. It is ultimately in health and healthcare and public health about relationships. It's about those relationships and what role does technology play in supporting those relationships. And as you think about public health and digital public health, you need to move from the determinants of health, which we recognize are much more than just healthcare, what happens in an exam room. It's what happens in the community, hospital to home, clinic to community. You have to think about the social, the environmental, the behavioral aspects. Of course, you have to think about the genomics as well as the clinical care and the access to clinicians or community health workers wherever you are. You have to think about the data that represents those determinants, and you have to consider how those need to be weighed based on the knowledge and the evidence we know. We know that social, environmental, and behavioral determinants of health represent 70% of health outcomes. So if our interest is in having healthier outcomes and living longer and healthier lives, then it is essential that we have the appropriate data sets that represents those determinants. And then providing access to that information, those insights, whether through analytics or artificial intelligence or machine learning, to the decision makers to give the right information at the right time to the right person in the right format, so that it's something that actually is going to be embraced. And there's a time and a moment for a different intervention to be taken where the data isn't too late, the insights aren't too late. For stakeholders in health and healthcare and public health, governments, of course, life science companies, providers like hospitals and healthcare systems, community health workers, primary care providers, specialists, and then payers. And I want to include here in payers, employers. Employers and large multinationals like IBM have an extraordinary influence and opportunity by how they create a culture of health, how they create it for their employees, their families, and their communities. And they are often the largest purchaser or payer of health and healthcare. And so as a buyer of care, you could demand that the system delivers better. So as we think about determinants, data, and decisions, and I'm fortunate to be a part of the 3D Commission, which is a commission sponsored by the Rockefeller Foundation. This is so essential as we think about the age of COVID and beyond. So as you once again look at the applications and the ways in which you can leverage this technology, from what I like to say, from benchside to bedside to curbside, or for the more traditional microscopic views of the world to the clinical views of the world. As a primary care doctor, I trained in taking care of patients and learning about the microscopic aspects of the pathology of disease. And then the curbside, which in so many ways I've learned to appreciate post my medical education and training. The understanding that the communities in which people serve, there's so much. If you reflect on the 8,760 hours that we have in our year, and how many hours are typically spent in a clinical setting, it's the average person only has maybe two hours and maybe 30 minutes with a physician in most of our developed world countries. That's the dynamic that exists. And so much of health comes outside of those hospital walls, those exam walls, in the community, in what I call curbside. So how do we leverage technology in each of these areas? So digital public health, clearly you've got to think about the microscopic. We are in a race for a vaccine. We are in a race to find drugs that can be repurposed or developed, convalescent plasma for COVID-19 patients. We're in a race to look at ways to recruit people into clinical trials. So this is an extraordinary opportunity for us to leverage technology to support that effort. And this is one example of thousands of publications that we published at IBM Research, and it showed that we were able to find very early, and it's had 40,000 downloads, this article, working with our partners, publishing one of the mutations that are connected to potentially targets for vaccine development. And so this was one piece of evidence and science in that space. As you move from benchside to bedside and you think about the clinical opportunities, we're very proud of the work we've done supporting these key stakeholders, these key partners in the Middle East as it relates to especially the clinical workflows, the integration of health systems. If you think about the silos of data that I was referencing before, the need to bring different data sets together to leverage integration and intelligence so that you get the right insights to the right person. There are many examples that we have, and we're just very proud to partner with the Kingdom of Saudi Arabia, with the Cleveland Clinic Abu Dhabi, the Dubai Health Authority, as just a few examples listed here in terms of how we've leveraged our technology pre-COVID and now during COVID. And we definitely believe it'll be essential post-COVID as we redefine this new normal. And as you think about the curbside, and once again, I reflect on that, on the communities, particularly the vulnerable communities across our globe. And as we, as you know, this society, this global community reflect on the populations we need to serve, I want to emphasize those populations that are most vulnerable across the globe. And so we've worked with, for example, NHS Scotland on benefits that go beyond healthcare, social, human services benefits, and the ways in which we can change the paradigm of how those services are delivered and how we can better automate, better simplify, make more efficient the delivery of those benefits to those vulnerable families. And this is, once again, another example of leveraging data, analytics, technology to support such an important need, especially as we reflect on those vulnerable populations in the age of COVID. So going from that leveraging of technology, and I want to emphasize being data-driven, being science-based is really essential. This is, the picture here is the headquarters of IBM Research. It's known as Yorktown Heights in New York. And this is the headquarters for IBM Research. We've invested in research as a company since our beginnings. And we are very proud of how we've been leading in patents for 27 years and how that commitment to science continues to be so foundational to the work that we do. You need evidence-based interventions, you need evidence-based bedside, curbside insights. You need to be transparent. That's a powerful part of science, that data, those insights are transparent to the broader scientific community to look at, to analyze those results, to recognize there could be biases in the data sets. There could be biases related to the authors in terms of how they present their evidence and how they may have conflicts of interest. So this commitment to science is, in my mind, so foundational to the values we have in the age of COVID and digital public health. So this is my last slide, and I think I just made a couple minutes before 20. So what do we value in health? So in the US, we have this reference we call value-based care, which I would suggest is unique, as I've had the good fortune of being a global public health professional and traveling across the globe, and now traveling quickly across the globe through mediums like this. It's extraordinary to think about how the values, the culture of health is different in different settings, in different countries, in different communities. But in the age of COVID, we have an opportunity to challenge ourselves. What are the values we have as we reinvent our health systems, and we think about our global community together across the G20 and beyond? So science, I think, is essential. I referenced, and I made a couple references to family there. I think it's so essential now that we recognize how globally connected we are and how we're often now more reminded than ever as we think about the vulnerable populations of COVID, the elderly. I think about my mother, who's definitely in a risk factor category, and taking care of her as well as my children and my wife. So this idea of family and how we can, in the age of COVID, address that more solidly, more effectively. Resiliency, if you think about the mental health curve and the challenges there, how do we promote mental health? How do we prevent disease, not just treat disease, so prevention? And then the issues of equity, and of course the issues of community. So on that note, I really appreciate the opportunity to connect, and I'll hand it back over to our chair, Mahmoud. Thank you.
Thank you. Thank you. It was very useful and insightful presentation, Dr. Reed. I'm sure we will generate some more questions and discussion later on. So moving on, let me introduce my second speaker, that is Dr. Kyla Plato. She's a researcher at INSERM, which is in France, and which is one of the key public health institutes. And she has done a lot of research on applying complex system science to infectious diseases. Over to you, Dr. Blair.
Thank you so much for the introduction, and thanks so much to the organizer for this very important event and for giving me the opportunity to take part on it. This is really an honor. Okay, so I would like to take advantage of this presentation to speak about some work we did in the last years on the global propagation of epidemics. So I will speak mainly about this coronavirus pandemic, but I will also tell you some stories about a close relative of COVID-19, that is MERS. And the work I will describe was done in collaboration with junior and senior researchers in my institution, in INSERM, and researchers at Public Health France. Yeah, so we are witnessing many emerging infectious diseases events recently. These are serious threats, and we have a specific, when we deal with an emergency like this kind, we have specific epidemiological goals. One of these goals is to assess the epidemic situation, providing information, providing context awareness, information on number of cases, on how the epidemic is spreading, for instance. Then we have the need to quantify the risk of further spread and provide projection on the evolution of the epidemic. And we need to inform intervention planning, like, for instance, provide scenario analysis of what may be the impact of possible interventions. But for doing that, we have some challenges to tackle. In particular, normally we have a new pathogen spreading in the population, so there are many unknowns. We don't know the transmission mechanism, and we don't know exactly the clinical manifestations. And at the early stage, we may have limited epidemiological data. And this is an intrinsic problem, regardless the quality of the surveillance system, because of the difficulty in the case definition, for instance. And a third challenge I need to mention is the human factor. So people, of course, react to an epidemic emergency. So we have awareness, we have behavioral change, we have spontaneous and coordinated public health response. All these mechanisms are quite complex and difficult to capture. But we have also resources to tackle these issues. In particular, we have, let me mention, big data. So data on human population, like demography, data on mobility at different scales, like local mobility, for instance, commuting, for instance, mobility reconstructed with my mobile phone information, and we have also global mobility and information on human-to-human contacts. But it's important to remember that these data don't speak by themselves, and we need to interpret them. They are always biased, and they need to be combined and to merge. And in order to do so, we need stronger quantitative approaches like statistical, mathematical, and computational modeling. And I hope to provide some example of these by discussing the case study of global propagation of epidemics. So I like to show this picture. This shows the pattern of the early spread of the 2009 influenza, H1N1 influenza pandemic. So you can see the countries that were first infected by the infection, by the virus. It's important to notice that, well, the epidemic started in Mexico, but it's important to notice that usually when you have an epidemic in a certain area, and there is a global concern of this epidemic, foreign countries are heightening surveillance. So you have a strong attention, and normally the information, the first cases arriving in new countries is a good quality information. So we know a lot about these cases. So we These epidemiological data represent a very good resource. And especially if we combine this resource with high traveling data. Here I'm showing you the pattern of propagation, global propagation that may appear random at the first glance, but actually is driven by the underlying air transportation network. So to discuss this more in depth, I would like to tell you a couple of stories, and in particular, a study we did on MERS. We analyzed the epidemic at its early stage, and that period it was there were strong uncertainty, for instance, on the transmission potential of the epidemic. And what we did is to use a strategy actually quite used in several studies. So we used information on traveling cases combined with information of traveling flows to infer the epidemic situation at the source. So in this case, Middle East. And we did this by using a computational model for the propagation of epidemics. I'm talking here about the GLIM project. It is a project, a big collaboration led by Northeastern University in Boston. And with these computational models integrate several data layers in human population, in particular demography, local mobility, in this case commuting, and high traveling flows. And on the top of this, we can add a model specific for the particular epidemic we are considering. So in this case, we have the specific model for MERS. And by running computer simulation, exploring different scenarios combined with inference, we could quantify human-to-human transmission, and we found that it was subcritical in agreement with other studies. And we could also disentangle the relative role of human-to-human and zoonotic transmission. We could provide some assessment of the epidemic situation in the Middle East and provide projection for further spread. And as I said, this kind of reasoning, although implemented in different ways, but this kind of reasoning of looking at the international pattern to better understand the local spread at the source was widely adopted. In particular, let me mention the study of Imperial College on the current coronavirus pandemic. So with a similar approach, analyzing traveling cases, they inferred the number of cases at the source in Wuhan, and they found that indeed it was much higher than reported, just so providing an early warning to the international community. As a second story, always related to MERS, I would like to discuss a study we did on a more extended period, and here again we focus on traveling cases. We reviewed all 22 imported cases confirmed by WHO up to mid-2015, and we collect all possible information on these cases. And the question we wanted to answer was why some cases, once arrived in destination country, were able to generate secondary transmission while others not. And what we found is that cases that generated secondary transmission were having longer hospitalization period from the beginning of hospitalization until they were identified as MERS cases and were isolated. So this study confirmed the critical importance of hospital nosocomial transmission for MERS. And we wanted to go more in depth into that, and I'm showing you this plot. So here, all these dots are the duration of hospitalization of these patients through time. And we plotted it against the score of Google trend for MERS. So the search globally of the word MERS and MERS-CoV. And you can see that Google trends show clear peaks of attention. These are peaks, let's say this is a proxy for collective attention. And actually, I'm not showing it this because it would be too confusing, but if you show like the disease outbreak news, number of disease outbreak news by WHO or number of ProMed mail posts, we find a strong correlation, a strong resemblance between Google Trends and these indicators that we may think about them as indicators as proxy for public health attention. So what we find here is that the duration of hospitalization was clearly shorter in the period of high attention. For instance, if you look at the spring 2014, a high collective attention was prompted by the surge of the epidemic in the Middle East, and international cases were quickly identified. So we concluded that global collective public health attention is associated with increased preparedness. So, okay, let me move now on the main topic of my talk, that is the current coronavirus crisis. So just to provide some context, I'm showing here the plot, the number of cases as provided by WHO. I put in some arrows just to summarize the chronology of the early spreading, the early period of the outbreak. So the epidemic was first reported at the end of December, but during the month of January, February, the epidemic was mainly confined in China, in particular in Wuhan. And we were experiencing the first imported cases outside China. But then the stronger containment measure in China apparently slowed down the epidemic there, and for a short period we were thinking maybe we would be able to contain it. We were having a strong containment measure in China and controlled borders, identification, isolation of cases abroad. So the question that we wanted to address in that period was, are these measures able to contain the epidemic? Well, actually the answer was clear later. The outbreak in Italy and then in Europe, let's say, represented the beginning of a different phase in which we had a global propagation, and then coronavirus was declared a pandemic. So the work we did was having the goal initially to provide risk assessment for the global propagation. So we use air traveling data to provide projection on the risk, relative risk of countries in Europe. Our high-risk maps were in agreement with other studies, always based on high transportation data, like Kinaxi, a collaborator, and Bogosh collaborators. And importantly, this was a good predictor of the actual spreading pattern of the epidemic. But actually, the spreading was very fast. At the time we were preparing this report, 2 among 3 of the countries that were considered high-risk experienced cases. So we wanted to analyze this more in depth. So again, with a similar approach adopted for MERS, we reviewed all international cases out of China confirmed by WHO before middle February. And we collected, again, all possible information, including data of travel, data of confirmation, and the information on transmission clusters occurring outside China. And you can see that, while traveling data was not available for many of these cases, but actually by using imputation, we could infer this, and in this way we could show that the travel ban in Wuhan had a strong impact on international propagation. So the number of imported cases outside China went down rapidly once this travel ban was implemented, and it approaches very low levels. While instead international travel restriction of flights with China had a limited effect. And actually, number of importation was quite low at the beginning, but at the end of this period, we had a sharp increase. And these dots on the right represent importation coming not from China, but from countries in Europe, signaling a new phase of the epidemic. And a situation in which the epidemic was not anymore centered in China, but was showing a multiple centers. So we conclude from that restriction were effective. Travel ban was effective in reducing protection. That was a good news, but actually, by analyzing closer these imported cases, we found that that actually many cases went undetected. So what we did is to reconstruct all transmission cluster by collecting all the information available. And we found that for the majority of clusters, for many clusters, not the majority, we were having information on the index case. So the index case was a traveling case. And but for some clusters, we were not having information on the index case. So by making the reasonable assumption that the index case was a traveling case, so in some cases we didn't have a detected traveling case, but we knew that it was a traveling case because of the context. So from this, we realized immediately that many traveling cases were missed, were not detected, simply because we saw cluster popping up with no source. And we could use some inference to quantify this effect. At the end, we found that only 36% of traveling cases were detected. So, controls and the portal identification failed. This is due to the complex natural history of the infection. Later on, this was well understood because of a high percentage, relative high percentage of mild or aspecific or absence of symptoms. And the cases, the arrival cases missed generated silent epidemics in the foreign countries. So the reduction in traveling cases due to the ban one arrived too late. So I can conclude my presentation. So I show you some examples on how we can analyze the global spread of epidemics by combining eye traveling data and records of traveling cases that often are quite accurate to provide a risk assessment, but not only, also important epidemiological and public health understanding. Actually, one challenge here is, again, accounting for responses, spontaneous reaction of the population, because as I saw you, I mean, we analyzed the early spread of the epidemic, but actually the later stage was much more complicated because flights were cancelled at large extent, so we have a huge disruption of the air transportation network, and to account for this effect is very complex, because of course we need more data, but again, data are not enough if we don't find appropriate modeling approaches, statistical computational approaches to make sense of them. So I would like to thank you again for the attention.
Thank you, Cara. That was very helpful, and I enjoyed listening to all of your good studies, and I'm sure so has all the audience. So this is a good time that we need to move on to the question and answers. I have received a number of questions, but looking at the time limit, I am going to pose a couple of questions that I would ask my speakers to reflect upon. Let's start with the first question. What solutions digital health and data can provide to prevent any future epidemic? Q, it's over to you.
Yeah, so the opportunity as it relates to prediction is really essential, as I was referencing the determinants, data, and decision paradigm. So when we're talking about predicting a next pandemic, as my colleague was speaking about, like something like air travel, that type of determinant and data could be very useful to help predict. So the piece I want to emphasize here is the issue of trust across an ecosystem. So health is very local. You need data and determinants from multiple typical entities stakeholders, hospitals, health systems, payers, governments, life science companies. So bringing that data set together, it's often not about the data. I would suggest we don't want perfect data to be the enemy of good and predictions, but ultimately it's about bringing that data together, applying traditional analytics, potentially machine learning and AI analytics to better predict, to better personalize, and to prevent those epidemics or pandemics.
Thank you, Q. That's helpful. Any further reflection? I think the work you and your institute did, there might be some things we can learn that how best we can prevent the future epidemic. Of course, it is not prevention, but mitigating and managing as well.
Yeah. Well, of course, from every pandemic, every epidemic, we learn something, and the response to the next one is always more rapid and more efficient. But I think that the most important challenge is to quickly acquire the knowledge needed to tackle the infection. So if we don't know what we are talking about, it's impossible to adopt appropriate measures. I think in this case, the scientific community have a huge responsibility, and then the public health one to let's say synthesize the scientific information that quickly and in maybe uncoordinated way emerge in the beginning, and to provide recommendation. So central is quickly understand the disease infection natural history, the transmission modes. So this is becoming in the pandemic. I studied in my career. I see how this became increasingly fast and rapid. So that's a good thing.
Thank you. Both of you mentioned the need for more data. It is easy to say, difficult to do. So what's your experience in collecting, analyzing, and developing certain products or outcomes based on the data? And Q, I know that I think IBM Watson and you have got a very good platform. So any examples, or very briefly, you can say that what sort of data you were trying to collect in terms of this pandemic, and plus what challenges you faced? And then same question I will ask to Kyle.
Yeah, I would go back to what I referenced. Data is essential to benchside, curbside, bedside, those types of opportunities to get insights, to get the right information to the right person at the right part of the workflow to make the right intervention. So we've learned that there's a lot of publicly available data out there. Data on, for example, non-pharmaceutical interventions in the age of COVID. That's publicly out there, but it's typically situated on multiple websites and multiple government sites. And so collecting that, as we've created a dashboard for non-pharmaceutical interventions across the globe, typically requires a level of human intervention to validate the websites as being trusted sources of information. But then you can use AI and other technologies to scrape the data on a regular basis and get it accurate. And then the key is to bring it to different stakeholders. So I would suggest, there are many people who say we don't have enough data. I would suggest we have enough data to at least do much better. But then a lot of the challenges about these issues of trust and transparency and data principles. And many parts of the globe have different cultures as it relates to data and whether or not I will share my data with, a government entity or a private sector entity. And so these principles need to be globally understood and embraced, recognized, transparent to the global citizenry, but also, recognizing the role of the private and the public sector in supporting the infrastructure to support those insights that come out of the data.
Thank you. Kyra, any reflection?
Well, okay. From my point of view, I think that the big challenge I mentioned during my presentation is to capture human behavior, because human behavior determine how an epidemic spread. It's a fundamental component in how an epidemic spread. But it's important to notice, I would like to stress that an epidemic is a collective behavior. so a collective phenomenon. So we don't want information of a specific person, of you or me or what else. We want, let's say, the behavior of the population. So this is why the data, normally an epidemiologist, an epidemic modeler need are data on mobility fluxes of you aggregated data aggregated spatially. For instance, an important, let's say, something important happened during this pandemic is that a lot of people got access to mobility proxy from mobile phone data. These data are absolutely anonymized and aggregated and simply tell us how people are moving around. This information is fundamental, for instance, was fundamental to understand the impact of lockdowns implemented in many countries, and this is an important resource. And yeah, we witnessed an advance and improvement of this during this pandemic.
That was a very good added value, what Q said before. There is another question, maybe the last question. I think we have put a lot of emphasis on digital health. The question is digital health and tools are enough in this fight against pandemic, or we need to supplement it with some other approaches? I know this is a challenging question because while the topic is on digital health, and we cannot make digital health panacea for everything, but I would like to have your views again, that do we need anything more than digital health in order to deal with pandemic? So Q?
And so we've been reflecting on this at IBM quite a bit and with our clients and our partners. And so I'm going to use the acronym of COVID to talk about the areas that we think are essential in this new era. So C is collaboration. As I mentioned, the collaboration across an ecosystem, across academia, across media, across hospitals, health systems, governments, life science companies, citizenry, you can't underemphasize the issue of collaboration and trust. I think COVID has also made us realize that health is not just my health. Candidly, when I wear a mask or, with the asymptomatic, the pre-symptomatic, the post-symptomatic spread, the O is our health. We need to recognize this is all about our health, whether it's me, my family, my community. And so, 100 years ago, infectious disease was the #1 killer. And then non-communicable and chronic diseases became the big focus for us as a society to get those extra years of life expectancy. And now infectious disease is back upon us in more ways than ever, at least in the developed world. In the developing world, infection still is incredibly prevalent. So the V is values, as I mentioned. Do we value equity? Do we value resiliency? Do we value community, science, and also resiliency and prevention? True prevention is where you prevent the disease. I is innovation. I would suggest digital health represents the cultures of healthcare and public health and tech. In technology, we're very used to iterating and changing very quickly. Health takes 17 years from discovery to delivery, as we discover. That's a long time. We don't have time for a global pandemic to wait 17 years for discovery to delivery. And then the last one is D, data, digital infrastructure. So that would be my recommendation.
Thank you, Q. Kyra, anything you would like to add to this?
Well, I think that digital art is, of course, revolutionizing our way to tackle pandemic. It's improving our capacities. But my view is more a view centered on people and the expertise of people, in particular, people working on public health. So we need experience, we need the capacity of interpret the data. So I stress that the data provide always, by definition, a partial information. Even there are no perfect data. Even if data are without errors, still they provide a partial information. So we need the experience of interpret them, and also another human component, let's say that for me it's important, is the human component in needed for gaining trust of people. I'm talking about, for instance, one example very debated is the one of digital contact tracing. This is a good example. This is something that is really promising. I really, let's say, I'm really interested into this, but I think that the best of this is when this is combined with manual contact tracing, with the intervention of expert people that can close, follow people's, the patients, and provide assistance. This is an important aspect.
Thank you, Cara. Thank you, Q. I'm sure what you presented, what we discussed through questions, it is going to add a lot in the knowledge we are generating through this summit. And the knowledge is what we need as humanity and need to take actions. So I will thank both of you. And now next I will summarize and reflect what we discussed and what should be the way forward. So when we started this session, I talked about the definition of public health. So we are clear that the digital public health is the way forward. And we need to be mindful that through this summit, we need to ensure that we should not be in future using the word digital public health, rather digital should be part of public health, and our definition of public health should encompass it. What other thing I can reflect on that what pandemic has done to us as a society, or in particular to the public health in all over the globe and in every country, on mainly on three aspects. First one is that we came to know about the importance of data. And I say data, not like because I deal with it, or in Scotland we are managing it pretty well along with a number of other countries. But the question is, this is the first time from the front line to the policymakers, they start realizing the importance of data. But I would like to say that it is not the data, because we do have enough data. I say that we are data rich and intelligence poor. So we should be able to change that data into applied intelligence. And those, the good speakers, they already mentioned how they were able to change some of those data into applied intelligence. So we should be mindful that the first thing we have learned, we need to have more applied intelligence. Second thing, we start realizing health is connected with wealth. Because what has happened in pandemic and COVID, and which is happening with the non-communicable diseases, when our health is bad or the health outcomes of any country is bad, then it means that their GDP is low. So we need to collect more applied intelligence or generate more applied intelligence in terms of broader determinants of health. Because these broader determinants of health are going to help us to improve quality and decrease costs. And the third thing which I've learned, which is very important, is that we are not in a position to ask people that they should be thinking that we can provide them the services. We should be thinking how we can co-create health. In order to co-create health, there are a number of examples quoted in many sessions yesterday, which is happening in Kingdom of Saudi Arabia, providing them tailor-made information on their mobile phones so that they can co-create health. So these are the three lessons that are very important for our public health and for our digital public health. Then I also say the time has come that we need to move from stethoscope to datascope. It means if our clinical interventions were very important in the past, and we were using those clinical interventions to improve the public health outcomes. Now we are generating a lot of data, and we are able to analyze it, and we are able to change them through the machine learning and other tools into applied intelligence. So it means that we need to start looking into the data scope. We need to let our workforce, everyone who is listening today, they need to start thinking, have they got the digital health or data literacy? It means, are they able to access, understand, and use the data and digital tools? So I would conclude by saying that this was an excellent summit. It has given us a good platform. thanks to Kingdom Saudi Arabia, G20, and the organizing committee. And I'm sure we will hear more from the people. But the take-home message is, if you want to make a difference, then you have to include digital public health in your strategies. Thank you.
Thank you all for such an insightful discussion on digital public health and how technology has changed the science of public health. Before we start the next session, we will share with the audience 2 polling questions. The first question, on a scale from 1 to 5, how strongly do you agree with the ability of wellness technology in supporting mental health during pandemics and crisis? 1, strongly disagree. 2, disagree. 3, neutral. 4, agree. And 5, strongly agree. You have 30 seconds to answer. So as we can see, the results, the majority actually do agree with the ability of wellness technology in supporting mental health during pandemics and crisis. So we'll go to the second polling question. In your view, what are the main challenges to use wellness technology to support yourself and your patients during COVID-19? Choices are, you can actually choose multiple answers. It's optional. 1, technology adoption and acceptance. 2, technology maturity. 3, technology cost. And 4, technology proliferation, such as the use of smartphones and wearable devices. We're going to show the results in a few seconds. As we can see, the results, the numbers are close, but maybe the last option, technology proliferation, such as use of smartphones and wearable devices, are chosen to be the main challenges from our audience to use wellness technology to support yourself and your patients during COVID-19. Well, we will discuss about this topic more, the role of wellness technology. To do so, it's my pleasure to introduce the session chair, Chief Executive Officer of the Australasian Digital Health Institute, Dr. Louise Chaper. Welcome, Doctor.
Hi, salam alaikum. Hello, I'm Dr. Louise Chaper, and it's my pleasure to welcome you to this session on the role of wellness technology. For today's session, we are joined by 3 global experts in the field of wellness technology, and we're coming at you from 3 different countries. First up, we have Associate Professor Arif Rana from Nova Southeastern University, USA. Dr. Rana will be joining us from his home in Fort Lauderdale, Florida. And today he will be discussing wearable technologies to monitor high-risk patients during pandemics. Please join me in welcoming to the Riyadh Global Digital Health Summit stage, Dr. Arif Rana.
Thank you, Dr. Louise Chaper, for the introductions. So, assalamu alaikum wa marhaban wa ahlan wa sahlan. Normally when you see the thank you slide, traditionally, the thank you slide always comes at the very end of a presentation. And so don't be excited that my presentation is about to end. No, but I really wanted to just take this time to really just acknowledge some people for their very hard work in making this event a true success. I begin with thanking His Excellency Dr. Tawfiq Arabia, who's the Minister of Health, for really sponsoring and providing us this platform. I thank His Excellency Dr. Bandar Al-Qanawi for inviting top scholars from all over the world to share their knowledge with us. Equal thanks goes to Ms. Wiam Ad-Dakhil for emceeing the summit. I would also like to acknowledge Dr. Riyadh Al-Hazmi for being a great educator and expanding my knowledge base on clinical business intelligence systems. Mr. Tariq Mohammed Rana for providing feedback on my work. Also to the wonderful people at Richard Atias and Associates for their technology support, in particular to Miss Dorothy Atkinson and her team. I had the pleasure of working with Jacqueline Gross, Mona Hamidi, Tausif Khan, Sophie Chitillo, Cesar Halal, Daniel Abrams, and Sarah Putterman. I thank Dr. Jawad Abdul Jawad as well. In addition, the chairs and co-chairs for making these sessions very engaging. Lastly, to the 60,000 plus attendees, like Shukran Kathir and Shukran Jazilan for taking the time to attend and really join us today. The title of my talk is really Wearable Technologies to Monitor High-Risk Patients During Pandemics. And here there are three entities that are of interest to us. One basically here is the wearable technologies, what they are. The second is high-risk patients, and the third is pandemics. And I thought what would be very nice is if I could just give you a little bit background information on all three, and then put everything together. We begin with wearable technologies. So by definition, wearable technologies are devices that are worn as an accessory, right? And there really is a wearable device for every part of the body. So as can be seen in the illustration and the figure on the slide, there's devices for the face, right? There's devices for the hands, the legs, the feet, and the whole body itself. Now, these devices really collect, track, and they sync data to either a smartphone or a computer. The sensors really record daily activities and biometric patterns. And by health sensor, what I'm really talking about is the hardware, software, and the data model analysis, plus the artificial intelligence. Okay. So the uses of wearable technologies are many. I've listed some of them here, but they're mostly what we see them being used today really are for biometrics. And biometrics, we're talking about the monitoring of like the physiological functions. Here we're looking at the vitals, like the patient vitals, the temperature, their heart rate, their blood pressure, right? Maybe we're detecting their motions, their sleep patterns, and so forth. We can also use wearable technologies to do electrocardiograms, as well as augmented reality. The augmented reality is something that's very new that we see coming up and emerging. Another use of the wearable technologies is doing GPS. This is really the global positioning systems where we do real-time location tracking. Last but not least, you can also do real-time contact tracing through radio frequency identification. So here in this slide and then in the next couple of slides, I'm going to be displaying and talking about some of the wearable products that are out there from various companies. Now, for just record purposes, I would like to just state that in no way am I being financially compensated from these companies, so there is no conflict of interest. So we'll begin with the smartwatches. And usually in the ones that we see very popular in the market today are like the Galaxy Active 2. Some of you may actually be wearing them as I'm presenting. These can be synced to a mobile device. A Fitbit is another example of a smartwatch. And then you also have the Apple Watches, which is also very popular. Right? The watches, just to let you know, they really do collect the biometric data, and that data, like I said, can be transferred to a computer, laptop, or the cloud. We then move on to the next example of a wearable technologies, which is they're called head-mounted displays, and I provided two examples here. One is of Google Glass, and the other is Microsoft HoloLens. Now, this wearable technologies is used for augmented reality. We see a lot of businesses using this item to train their employees. At the medical school where I presently teach, we are implementing these head-mounted display to train our medical students when we go to teach them anatomy. We also have garments, right? So these are smart biometric garments, and the biometrics are embedded within the garment itself. So this is an example of a product from Hexoskin, and this garment, it has been designed for both males and females, and you can see that here the vitals that this garment can pick up or track or collect data on would be the individual's blood pressure, their activity level, their temperature, their oxygen levels, 3-lead ECGs, and their breathing rate and volume. Now, this data again can be transferred to a mobile device, as you see in this slide. We also have something called like jewelries or medical alert systems here. So I've provided three examples. The first one that you see is the Aura ring. It's very light. It's made out of titanium. You wear it like a regular engagement ring or a wedding ring, and this may very well become people's wedding rings and engagement rings in the very near future. It's really packed with infrared LEDs, temperature sensors, and an accelerometer and a gyroscope, everything all in one in this small ring, right? And this ring really captures an individual's pulse, their movements, and their temperatures. The second is the pulse ox, and the pulse ox really became very popular in the US when the pandemic happened. At one point, it was very hard to, they were all sold out. And we know that in the pandemic, one of the things that happens to our patients is that, their O2 levels begin to drop. So a lot of the people started to purchase the pulse ox, so that they could maybe keep a track of their oxygen levels. The third thing that sort of falls into this category in terms of jewelry is like the life alert system. And what you'll notice on the slide is that there's a small little a module that you see that can be placed around your neck like a necklace. And this life alert really became very famous in one of the ads, for life alert. There was this elderly woman who sort of fell in her house and no one was there. So she presses the button on this device that's around her neck and she yells, "Help, I've fallen and I can't get up," And moments later in the TV commercial, you saw the ambulances arrive. So again, these are just specific examples of wearable devices. There's another category of wearable devices called SAMDs. These are software as a medical device. So here I've provided two examples that we see in the market. One is the RFID. Now these RFIDs were first introduced. We first saw them in clothing department stores where the stores put these, the stores basically put them on the clothing items so people wouldn't steal. But now we're using them to track patients in hospital. The other is a cardiomobile. So here we place the leads on the back of the phone, which is what you see in this diagram, and you can take ECGs here. That was all about mobile wearable devices. I want to just talk about high-risk patients. Now, when the pandemic started in the U.S., right, there were many patients of interest, right? We were all being told that we should all be careful. But then the focus then somehow the focus then got shifted to particular high-risk patients. So it really started out with the elderly, right? That often had chronic health conditions like obesity or diabetes. Then the focus moved on to like the healthcare workers who were actually treating all of these patients. And then now with the schools opening up, we see a lot of attention being placed on children. However, apart from those high risk, apart from those, we also, there are other categories of people that fall into this category. So pregnant women, people from indigenous races, groups that are underinsured or uninsured, really also are considered high risk patients in pandemics. Right. So the needs, I think it's also important to know the needs of high risk patients. And sometimes technology can't provide the solution for everything. If all of you remember, a number of patients who had the COVID virus, complained that they could not breathe. And there were also a number of cases where the patients would say, I cannot smell. So we don't really have any medical device that can pick up symptoms of like patients not being able to smell. So one of the biggest important things here is that the voice of the patient really becomes important. And we have to ask ourselves, are we really listening to our patients? Now, when EMR systems were being implemented in medical practices and hospitals, everybody was very ecstatic. There was talk that the technology was going to reduce medical errors, possibly lower the health costs, And when we saw the implementation of the EMR systems, one of the things that we saw was a decrease in communication between the healthcare professionals and the patients, right? So, let us not do the same here in this pandemic, with these devices. And what's sort of important is that there are some patients that really are low-risk patients that can turn into high-risk patients if we don't really listen to what they have to say. And in the United States, about 18% of the rising patients escalate into high-risk category when they're not managed properly. Okay. Now we sort of move into the third entity, which is the pandemics, right? So the question is, what really is a pandemic? We know that epidemics, right, is a disease that affects a large number of people within a community, right, a population or a region. So a pandemic, by definition, is an epidemic that's spread over multiple countries or continents. So you can basically think of pandemics as having passports. So it's really an epidemic that's just like doing some traveling here. And in this slide, I've listed some of the pandemics that we've encountered in history. The Spanish flu being one, the Asian flu, Hong Kong flu. We had the AIDS pandemic, the H1N1 swine flu, and now in 2019, 2020, we have this the COVID-19 pandemic, and we have to date there are over 700,000 death tolls that have resulted from this pandemic. So it's sort of important because with that high number, I think it's important for researchers and scholars, right, to really take a look at some factors for consideration. And in here, what's important is that we have to ask the 5 W's and the 1 H. So the 5 W's are the who, what, when, where, how, why, and then the H happens to be how. So some of the questions we should be looking at is, who contracted the disease? Here we're determining who our high-risk patients are. What symptoms are they presenting with? Right? It determines the spectrum of illness. When did they contract it? It determines the timeline. Where did it start from and where is it going? It helps determine the geographical spread. Why? did they contact it? It helps determine the context, and how can we make more sense of this data collected? It determines the strategies that lead to a solution. Now, there are a number of factors that here we have a number of strategies that we can use based off of the factors for consideration. Now, all of this really, these current strategies, are up for debate, and there is a lot of debate on them. But we initially started with surveillance, then we were told then the focus was on hygienic sanitation practices, then we focused on the PPEs. Now we move to social distancing and quarantine, but there's a lot of utilization of telemedicine, telehealth, and there's like drug development and vaccine development going on, right? So with all of that, with the three entities, now that you have some background, let me just quickly talk about some putting all the pieces together. So we have wearable devices in the market that detects changes in health patterns. So there was a DETECT study that was done by the Scripps Institute, right? And participants could opt in and basically share their data on their heart rate, sleep and activity levels, as well as respiratory symptoms. And the reasoning behind the study was that infected people really experiences changes in their health patterns. So these and all of these health patterns, are measured by these wearables. So if you're able to monitor the trends, you can then maybe spot an outbreak much earlier. We also have wearable devices for proximity alerts or contact tracing. So there's a company here called K2, right? They provide wearable devices for really proximity and alerts. So if we have two people, if there are two or more wearables in range of less than 6 feet, the device will begin to vibrate. Remember, in the pandemic, patients that had pulmonary issues, right? They really are our high-risk patients. So there was a study done by Tay, An, and Chung in 2017. They designed a remote rehabilitation system for a multimodal sensor-based application. And this system really it provided these patients with pulmonary issues, their exercise tracking progress, their patient performance, their exercise assignments, and their guidance. We also have wearable technologies for patients that are immunocompromised or those that are cancer patients. So there was another study that was done using a wearable activity tracker. In this case, it was a Fitbit Alta, and they found that using this wearable technique programs, it really had the potential to provide effective, intensive home-based rehabilitation. There's also remember, the elderly are also a high-risk group of patients, so there is a wearable device for them. It's really this belt that they have, and this belt basically has aided in it's really a fall detection system that's put around the waist, and it really can help the elderly, to basically for fall prevention. Now, there are several positives of having wearable devices. So some of them I've listed here is the real-time data capture, right? So wearables can really, they already collect a wide array of data. So these metrics are critical information for healthcare providers dealing with high-risk patients, with congestive heart failure, diabetes, and other conditions. Now, there is a talk that in the near future, wearables will most likely collect other additional biometric data like blood glucose levels and blood pressure through non-invasive sensors in real time. There's continuous monitoring, right? When we wearables provide a contextual continuous data instead of a snapshot in time that clinical monitoring provides. Presently, when we go to the patient, to the clinical's office, the clinician takes our vitals, and it's really just a snapshot in time. But if you're able to see a patient's, weeks or months worth of relevant data, it may help the clinician in better providing patient health outcomes. There's a lot of prediction and alerts, right, that these devices provide here. And lastly, it also increases patient engagement. And really, most individuals, want to have a role in improving their health. Patients who are actively engaged in their health issues will be more motivated to change, and wearables allow patients to interact with their health and lifestyle behaviors. There's also negatives. One is the cost and the affordability. Not everyone has access to these wearable devices. So just a smartphone like a Samsung or an iPhone, costs anywhere from $700 to $1,000, depending on how much memory you put in. The Oura Ring that I talked about is about $300 to $400. The Hexoskin is about $400. So these are wonderful technologies, but if you can't make them accessible to everyone, then we really may not be really helping everyone. There are privacy issues. So, in a presentation that Dr. Al-Hazmi gave yesterday, there was a slide on which he discussed, there was a study by the University of California that examined, perceptions of data sharing and privacy among various generations. And baby boomers who were born between 1946 and 1964 were most concerned about, data sharing and privacy, but 40%, that was 47%. But the Generation Z, which were born from 1997 to the present, were the least concerned at 28%. There's also security issues. So, in 2018, there were like 702 data breaches. It affected over 600 million people. In 2019, there were 493 there were 811 data breaches, which affected 493 million individuals. And to date, in 2020, we've had 540 data breaches that have affected 163 million individuals. There are ethical issues when we come to wearable devices. These devices are developed by private firms, and they're not part of a traditional healthcare system, so they're not covered entities. So the private firms in general have a commercial interest in selling their devices or the data the devices collect. So as such, these wearables are not subject to the same regulatory scrutiny and oversight as the other medical devices. And they don't offer the same level of control and privacy protection individuals have come to expect with regard to their healthcare. Right? So the market really, the market for the wearable devices really is just expanding. According to this slide, you see that there's a lot. In 2019, we had $32.63 billion worth of investment in this, and mostly we see it through wristwear and eyewear. And this is expected to grow. And I really end with this. I really would like to end my presentation just by sharing a simple little message with all of you. Now, in Arabic, there's a word to describe somebody who is unbiased, fair and just, and that word is called adil, right? For masculine, adila for feminine. Now, the root of this word is adala, which in the infinitive, right, means to act with integrity, straightness, or rectitude. And in this pandemic, many people have died, but this pandemic has also provided opportunities for growth. And it has brought like wonderful minds together, and this summit is a perfect example. So based on what I've heard thus far from our speakers, we have a lot of work to do ahead, and things will probably get worse before they get better. And the question is what lies ahead. We know that we need to collect more data. We need to better clean it and mine the data. And our prediction models need to be perfected even further. And we have to give thought on the information that we're disseminating. So it is okay to look forward and to provide hope, but giving false hope is very unjust, right? So let us strive towards developing products and publishing work that are really very conclusive. And everything else should be secondary to that. Only then, I think, will we be adil in our thinking and in our actions. And with that, I thank you for allowing me this opportunity to present.
Thank you, Dr. Rana. I look forward to diving deeper into your work in the Q&A session at the end of our next speaker. Now, for all of you listening in at home for this global event, whether you're at home, you're at work, if you're lucky, you might even be at the beach. I'm in Melbourne winter, so the idea of a beach right now in Melbourne lockdown is just complete heaven. So if you're there, have an extra good time for me, please, so I can live vicariously through you. But for all of you who are tuning in from all around the world, let me say thank you for all of the questions that you are sending in. They are coming up on my screen. Please keep them coming in via the Summit platform. We will endeavour to get to as many of them as we can at the conclusion of this session. Our next speaker is John Rayner, Regional Director, Europe at HIMSS Analytics. Now, John joins us today from the UK, and he will be speaking on the topic of wellness technologies in supporting the health of public healthcare workers. Over to you, John.
Thank you very much, and good afternoon, everybody. It's absolutely a pleasure and a delight to be virtually with you this afternoon. And thanks for the kind introduction. I'm John Rayner. I work for HIMSS, and as many of you will know, HIMSS is a global not-for-profit organisation focused very much on improving health through the effective use of information and technology. And we've used our maturity models over many years in 35 countries, and we believe that we've had an indirect effect on over 800 million people. My current responsibilities are in Europe, the Middle East and Africa. I just thought I would give a definition on the first slide. Wellness is something that one has to work at. It doesn't happen by accident or on its own accord. We have to take positive and meaningful action to remain or become well. In difficult times, the effort required to attain wellness is greater than it would otherwise be, and sadly for some, wellness is an absolute challenge and quite possibly an unachievable goal. I'm going to give some insights in the next 15 minutes or so from the perspective of a member of the public or from someone working in the health sector. Before I do that, I was a pre-COVID frequent flyer and regular traveller. I visited hospitals all over the world. I spent time in healthcare systems that were highly developed from a digital perspective and in some that were less so. It might seem obvious now in retrospect, but in the most successful countries, regions and indeed hospitals, I often came across three things. I think the first thing is the recognition that resources are required in order to make the necessary investments to innovate. And we all know, of course, that innovation helps organisations often survive in difficult times. It wasn't just the use of resources that I saw. It was the willingness to spend money on the right thing and to ensure that that spending had the desired effect. And those three things together are really quite important. The second is that I often saw high levels of clinical engagement, patient engagement, and citizen empowerment. And we often test for those things and for that level of engagement, specifically amongst clinicians and patients, by measuring the degree to which these groups engage with technology and use that technology in a meaningful way. The third observation, however, is perhaps the most interesting, and it's in those highly successful organisations, regions, and indeed countries that I saw examples of quite outstanding leadership. This was rarely one individual, but often a large group of individuals who were able to create a culture that allowed others to thrive, prosper, and to deliver amazing things. And you are often very much touched by the culture of organisations very quickly after spending a relatively short time in those organisations. And an old adage that goes back many years is around managing the culture and then letting the culture manage the business, which would suggest that the culture of an organisation is quite a powerful thing. And this really is where I start the journey today, recognising that when I speak to health professionals about what they have needed over the last 4 to 5 months, the concept of compassionate leadership comes very, very close to the top of their hierarchy of needs. They want leaders who can actively listen in order to arrive at a shared understanding, or who are willing to offer transparent communications that are free from spin, personal opinion and myth. And this is often more about, less about what is the matter and more about what matters to you. And one can imagine that certainly health professionals have a whole raft of different needs and requirements as we've passed through this very, very challenging period of time. And health professionals have often said that we want to be able to share our own feelings freely with others in order to obtain a response that is of mutual benefit. And I would suggest that compassionate leadership is so important in these unprecedented times. There's been approximately 500 deaths of healthcare workers in England and Wales, and similar numbers in the US. This cannot go unrecognised, and leadership styles must be responsive and be able to accommodate this extremely sad and unfortunate position. However, I do hear some saying that this is just about positive leadership rather than compassionate leadership. For some hospital workers, positive leadership seems to be a more palatable expression. Maybe for some, compassion may display an area of weakness. I personally think that's a bit of a cop-out. Positive leadership can mean all things to all people, and it can be a bit of a smokescreen for pretending that these problems don't exist. And then the individual may then go on to fail to address the endemic problems of potential bullying, harassment and discrimination. So compassionate leadership requires huge courage, resilience and belief. It requires commitment by you as a leader to be the best that you can be. It's about making that right decision on a difficult day. Compassionate leadership can be magical when we get it right. In preparing for the presentation today, I'd always thought about describing a number of personas, some typical personas that we often see when trying to provide examples of how different people have dealt with situations in very different ways. But then I realised that many of these personas were actually within my own family. So it seemed a much more personal thing to talk about my own family members and how they have come through the last 4 or 5 months and how technologies have helped to support them in this difficult time. So I'm going to start with my niece, Jodie. Jodie's 30 years of age. She's a paediatric ICU nurse, and I spoke to her on the telephone the other day, and she was amazingly positive about the experience, despite the very traumatic and often challenging times that she spent personally caring for patients. She said that the NHS in England had been great. They had provided free apps, mainly around mental well-being, mindfulness, to help with relaxation, yoga and exercise. But she'd also received online psychological support from the psychological medicine team in the hospital which she worked, and she had access to online counselling by the NHS Healthy Mind Service and some online CBT. And despite some quite difficult times, she remained positive. She said the last 4 months have been really tough. I trained as a paediatric ICU nurse and have suddenly had to learn how to care for adults, which has been a real challenge. We've had access to some amazing free apps as part of the NHS access to the online counselling through the Employee Assistance Programme. It's been really helpful, but the wellness apps were particularly helpful. So quite a positive story there. Nothing particularly sophisticated, as described by the previous speaker, but clearly very, very effective. My next special person is my mother. She's 89 years of age. She's retired. She doesn't take any medicine. She's fully mobile. She's mentally active, slightly deaf, and she really appreciates face-to-face conversation rather than conversations on the telephone. She often struggles to hear. She's been in self-isolation for the best part of 4 months and has coped really well with it. She's managed to get out and walk 3 or 4 kilometres every day. Didn't previously use technology, but none of the family members would really appreciate or anticipate not being able to have a face-to-face conversation with her. So we obtained an iPad, connections to the Wi-Fi, and that really has transformed the isolation period, the quarantine period for her. She said that the iPad has really been useful to keep in touch with my family during the lockdown. I can imagine to use a mobile phone and FaceTime but on the iPad, but not much else. If older people could learn to use an iPad to speak with family, it would improve their mental health. The main thing is being able to see someone's face. When you are a bit hard of hearing, it's useful to see someone's face, so you can see their lips moving. This is Megan. Megan is a family friend. She's 23 years of age. She's profoundly deaf. She's been deaf from birth. She had a renal transplant when she was 2 years of age, and she had a cochlear implant to help with hearing when she was 3. She works as a nursery nurse assistant, and she, as one could imagine, throughout the shielding process, because she was advised by the British government to stay indoors, to not go out, to keep away from people. She's used Facebook presentations with subtitles and a free flow app to share photographs with family and friends, and work for well-being to help with mindfulness, and she's done some yoga. She's used Zoom and Skype to stay in touch with friends, and she's had a wearable device to monitor exercise, steps and diet. Clearly diet and fluid intake is very important to someone who's had a transplant. I couldn't have much of a conversation with Megan for obvious reasons, but her mum said this has been a really difficult time for people who are deaf. Wearing a face mask makes it hard for Megan to understand people who cannot sign. Her mental health has been affected by a lockdown, and at first she had no idea why she could not go out. The hospital has only contacted us by phone, which has meant that all the conversations have been with me rather than with Megan, which isn't appropriate when my daughter is 23. Megan said, I felt very lonely. I've spoken with a counsellor who uses Sign on Zoom, and that has helped. So my daughter, age 26, she's an actress and a teacher. Lauren has suffered with one or two mental health problems in the past, from an eating disorder as a teenager to anxiety later in life. Lauren thrives on routine and meeting goals that she has set herself. She wasn't looking forward at all to spending 4 months in a very disorganised and unstructured way. She's used a number of meditation apps to relax. She has participated in exercise classes on YouTube. She's taught fitness and taught dance also on Zoom, and used IGTV. Motivation classes on Instagram were very much a part of her daily routine. Lauren says the last few months have been really interesting. As someone who needs a routine, I got up early for online exercise classes and established a timetable around my online teaching commitments. Technology contributed in a positive way to my mental, physical and spiritual well-being. It would have been very different for someone like me, whose mental health at times has been a bit fragile. I have continued with the healthier lifestyle that I established during the height of the pandemic. A couple more. My wife, age 57, is a Chief Information Officer. She has used exercise apps, MS Teams, to stay in touch with people from work and to work from home, Fitbit for daily exercise to monitor steps and miles, Zoom for video conferencing, and set up an Attend Anywhere for local GPs to continue to see patients remotely. Mandy says that the technology I was able to use at home reduced a lot of my stress that I would have associated with a 4-month lockdown. We were able to continue and in some cases accelerate projects because of the availability and performance of the technology. It's been very stressful it would have been very stressful to have had long communication gaps with my work colleagues. And finally, my nephew Tom, who's age 21, a final year student at Durham University in the north of England. Tom has used Zoom for weekly quizzes, a virtual running club using Strava. He took his final exams online over a 48-hour period, used a fitness tracker for competitions with university colleagues, and has participated in a number of online work experiences in banking, commercial law and management consultancy. Tom says, "This isn't how I wanted to spend my final year at university. No opportunity to celebrate, no end of year events and no graduation ceremony. The university have tried to maintain contact through social media and video conferencing platforms, which have been quite good. So just one or two final thoughts, maybe to pull some of these quite random stories together. The stories from my 6 important people have all mentioned technology, and the conversation with them didn't prompt that at all. The technologies are all relatively simple, intuitive to use, easy to acquire, and relatively inexpensive. Many of the technologies have been an aid to communication in the form of widely available video conferencing platforms. The stories from the 6 people have all mentioned mental well-being and have made the link between the technology and improving their own mental health. I didn't expect that. I expected for many people the technologies to be exercise dominated and communication. I think there's a clear link here between communication with people, having real-time conversations and maintaining one's mental well-being. Interestingly, when I look back at the HIMSS Analytics annual survey in 2017, I found that CIOs in all the European countries surveyed wanted to improve their leadership skills. In 2020, once again, our trend barometer found that technical foundations for telehealth were already in place in all European countries before the pandemic. They were not widely used, but they were in place. Video conferencing is now being used for well-being as well as delivering direct patient care. And for some, technology used in the last 5 months has been quite life-changing. Who would have ever thought that a video conferencing platform would assist with wellness? The truth is, out of all the technologies available, from the tools that help people become less sick, biometric sensors, healthcare workers, work-life balance apps, and even robots with infection for use within infectious environments, to data apps that help identify patterns of risk spreading, and risk stratification. The simple need to communicate with those closest to us has been an overwhelming feature of the past 5 months. And I will leave you with that thought. Thank you very, very much for your attention.
Wow, what a great session. Thank you so much for your presentation, John. Okay, well, we're going to have some fun now. So firstly, I would like to introduce my co-chair for this session, Dr. Zissis Kozlakidis. I'm going to say Kozlakidis. Did I get that right? Was it close enough? Welcome, Dr. Zissis. So Dr. Zissis Kozlakidis is the head of Laboratory Services and Biobank Group at the International Agency for Research on Cancer. So thanks for joining us, gentlemen. We've been flooded with questions, as you can imagine. The organisers of the event sent me a WhatsApp message and they said from the various different platforms that this event is streaming out, there's about 500,000 people watching right now. So no pressure or anything like that. We'll just have some fun with this. So I'm just going to throw out some questions that have come through. And again, thanks everybody for sending your questions in. We really appreciate it. It enables this forum to be much more interactive than you just sitting at home in your PJs listening. So it's great if to send in the questions. So the first question I will throw to you first, Arif, and that came in from someone asking about wearable technologies and how do wearable technologies contribute in digital epidemiology accurately, considering that many devices have their, well, this person said their own accuracy. So whether it's heart rates or step count or oxygenation levels. So what are your thoughts on the epidemiological aspects of wearable technologies, given their variability?
Yeah, I mean that's a great question, and unfortunately, unfortunately, one of the things that I had mentioned in my slide is that there are some negatives to these wearable devices. There's really no particular standards that are sort of the companies that make these devices. They're really not tied to any. They're not part of the covered entities. So in which case, I'm not sure. Each one of us has an agenda, right? So the question then is, what exactly are we doing with that data? And I honestly, from an epidemiological perspective, it's very hard for me to say how valid are the outputs of these devices. Now, we have, in the pandemic, we purchased 2 pulse ox devices for our family members, and from the same company, and they generated 2 different results. In terms of the measured outputs. So I'm not sure. It's very hard to say. And what I will say is that I hope researchers, epidemiologists can work very closely with some of these companies, to perfect the systems that are being produced.
Yeah, it is an issue, isn't it, regarding the standards that we associate with technology, whether it be hardware or an app. What are your thoughts? And I'll throw it firstly to yourself, John, on this one. You talked a lot about mental health and well-being. If any of us go to our app stores right now and search for mental health, you're going to get like a zillion responses of apps. And as far as I'm aware, there is very little standards when it comes to clinical governance standards of these wellness apps. How do you envisage the future looking where we can provide some sort of validation to these tools? John?
Yeah, I think that's a good question, and I think it will happen. So we've all got to look at other examples of technologies that have been that are calibrated. Technologies that are used in hospitals are regularly calibrated, regularly checked, normal ranges, go through an audit process. I think that the same thing will happen at some point to the apps that we buy online, much of which at the moment, of course, are hugely unregulated. I'm not so sure how that would work with a mental health app that doesn't particularly have scientific ranges and numerical values in the same way as some of the other clinical applications do. I'm sure some smart person at some point will sort that out. So, the answer is yes. I'm pretty sure that we'll see that online calibration, online governance of these devices in the future.
All right, thank you for the feedback. Sisis, you live your life in cancer research and biobanking. What comments do you have in regards to how you see the idea of the research that we usually do in cancer? So I'm thinking I'll rephrase that. So in cancer research, we follow very strict guidelines regarding how that research is done, and those systems have been perfected over many years. Do you see a role for wearable technology, sensors in the environment, so being able to gather data that could actually advance our understanding of cancer and how people live with it?
Yes, absolutely. There has been a notion of the exposure that's been put forward by the International Agency for a number of years, which means cancer is the combinatorial result of a number of exposures that we receive over a period of time as we find ourselves in different environments or different situations. And one of the ways in which we can get a handle on these exposures is through the utilization of wearable devices, where we can measure all these exposures in some way. However, again, it comes back to what John has said, the standardization and being able to compare against the data from the different data sets is a big issue for me.
Yeah, it is an issue. Yeah, that's right. And Arif, back to you on a similar topic as well. So a lot of the wearables that we use, I'm wearing one now. Hands up, all of you at home who are wearing one too. So if these are consumer, yep, okay, thank you, John. Yep, okay, we're all wearing one, at least one at least. And of course our phones.
I am not.
Oh, you're not? Okay, then. Well, I then have another question, but I'll follow up with that. So firstly, what I wanted to ask you was that most of these wearables are consumer grade technology, and we are seeing a push from those companies that own those devices to move towards more medical grade. What are your thoughts about the progression of, because the good idea with consumer-based technologies is it makes it more affordable, they become more ubiquitous, but if they're not sort of taken seriously by the medical profession, then their utility is going to have little utility, actually, isn't it? If it's not used by the medicos. So, do you see that progression happening in terms of that transition from consumer grade devices to medical grade devices that are still ubiquitous?
Yeah, I mean, I do see a progression in that, and I really hope that it does move towards that. I've always believed in. I mean, I work in academia. I mean, that's where I've spent most of my life, and for me, quality is everything. You know, so if we don't produce quality products, you know, they say garbage in, garbage out. You know, so if we can have standards put in place, and if companies, if commercial companies can produce high quality products, that's great. But in most cases, everybody likes to not everybody, but there are a number of people that like to cut corners, and they focus more on the profitability more than anything else. So that becomes their priority. But I think having put these standards in place, I think is a step in the right direction. And going back to your first question, I hope when these standards are put in place and these companies can work side by side with scientists, I think we can, our data will be much better, and I think we'll be able to make much strides in healthcare in terms of improving patient outcomes.
That's great. And for a question for all three of you, and I might throw to you as this is first on this one. So from what you said, we need to have the commercial-based companies that are producing these devices working alongside the scientists. Now, traditionally, scientific research takes a really long time, and because of the quality issue and the standards that are followed in that. So that takes a long time. In commercial circles, we have every quarter we're measuring our outputs, we're measuring our revenue cycles, our expenses. Is there a way for those two worlds to, instead of colliding, actually work closer together? Can we change with appropriate, you know, without walking away from quality standards? Can we change the way that research is conducted in terms of its time frame without sacrificing quality so that it aligns more to commercial outcomes? So question for yourselves, this is first.
Thank you. I believe we can do. We can do. We need to be a lot more open on either side of the well, in my view, it's the two sides of the same coin. So we need to be open to collaborate a lot closer and right from the outset. One of the reasons why the delay is happening is because we go back and revisit a lot of the data that has been collected in ways that is not useful, it's not meaningful academically, but yet it has been producing data, it's been collecting for a number of years. If the discussion was to be had right in the beginning, we would have saved a lot of time in that respect. So I don't see an issue in people working together. I think there are some very good examples where this has happened. The challenge that I see is in having the right frameworks to allow this work to happen, not just as part of one project, but to be happening all the time as part of our routine engagements in research and in the private sector.
Thank you. John, would you like to offer a response as well?
Yeah, a comment really, Louise. I think it's about fit for purpose and risk management. So I think there will be a market, quite rightfully, for devices that are very precise, that are of medical quality, and they will be used for certain audiences within a certain market. There will be other devices where that level of precision and quality probably isn't required. So the reason why my 6 important people were all very successful in using what they used was because the level of precision was relatively low. The level of quality was relatively low. So it didn't matter during a family quiz if the Zoom dropped or something of that nature. However, if it was a different set of circumstances and the risks were very different, then absolutely precision would be required, and we would want these devices to have undergone quality standards and be of medical quality in order to use them successfully and with confidence.
Thank you. Thank you. Arif, would you like to comment as well?
No, I mean, I think John summed it up very nicely. Yeah.
Okay, then great. All right. Well, then we'll have another question. Do all of you, and again, a question for you all, so you can think about your answer, and I'll reverse the order this time around. So how long is it going to be before we go to our local general practitioner or our local hospital, for an appointment, and instead of getting prescribed traditional treatments only, we get prescribed an app and we get prescribed a wearable? So how long is that going to take? Okay, so Arif, would you like to start?
Yeah, so it goes back to those. As soon as these devices can fall under the covered entities, then I think we'll see more of that happening. But when these devices are not, when they're not under covered entities, there are no restrictions in place. So I think something would probably have to happen. On a large scale, maybe at the federal level or something along those lines. I'm not sure. It's hard to say. But I know that people are using them on their own, and maybe a healthcare professional may, at this point, I think they offer suggestions, maybe get a Fitbit to encourage yourself to walk more so that you can lose your weight if you happen to be obese or something along those lines. But it's not, but no doctor here in the US at this point, I haven't seen them send a e-prescription, and say that, okay, this is your prescription, buy this app or get this app and so forth. So I think it'll take a while before that goes into full swing.
Thank you. Thanks for the comment. So John, what are your thoughts?
I think it's happening now. I've been in hospitals not too far from Riyadh, where the doctor has made the suggestion that certain technologies could help. The patient has then walked from the consulting room into the office of the technologist, who has provided a further explanation of what the doctor has just said, checked out the type of technology the patient has. Patients without that technology have been helped to obtain one from the hospital free of charge for that period. So it's been an integral part of the clinical dialogue. There's a commercial aspect to this, of course, as well. The patient in some ways, may have to pay for some of this, but it does happen. It's not frequent, but I've certainly seen evidence of technologies being used to support what the doctor's done and said.
And for those of the two of you who are based in the UK, because I'm aware there's an organisation that's getting some traction there called Orca, and I believe they're working with the NHS and what they do is that they actually do validate apps in the App Store for all sorts of health reasons. Are you aware of that service? Because I'm just, because as soon as those things take off, then hopefully clinicians will be less concerned about medico-legal liabilities or any other concerns that they have, and just work this into their kit bag, their toolkit of what they can prescribe. Are you seeing any of these things yet, Zissis?
Yes, I am aware of them, and I think it's a good way forward. What I would say is, from my side, a lot of the hesitation has been on the anticipated downstream demand that an app might generate. And we've had good examples through COVID and the use of apps in various different ways that allows us now to get a good understanding of what this downstream demand might look like. So that initial hesitation, I think, has been removed to a large extent.
Yeah, thank you.
I just
Sorry, yes, go on.
Yeah, it's the next step from the doctor recommending how to obtain further information online to the doctor saying, go to the national, go to the NHS site or go to the site from the National Diabetic Society, rather than just doing a random search. So the doctor knows where the curated professional information is. The same will happen with the wearable or the app or whatever it is. The doctor will know where to direct the patient, other than just say there are a whole load of exercise apps out there. Go and select one. I think it might help you to reduce weight.
Yeah, no, that's right. So we've had another question come in, which is, I think, a really good follow-on from what we were just discussing, and that's in regards to health inequalities. So we know that there are, unfortunately, health inequalities that exist from country to country, from region to region, from local as well, and unfortunately, it's not a problem yet that we have conquered at any level. So is there a danger that while that technology could actually increase those health inequalities? And take that question however you wish. Arif, would you like to answer that one first?
Yeah, I mean, we have health inequalities at this point, even prior to the wearables. I mean, and we have that in every country's. That's a very complex question to answer in terms of how can we improve health inequities. So people that come from very low socioeconomic backgrounds, may not even have the opportunities or the privileges to own one of these devices or utilize them and so forth. So I think that's why we probably, if healthcare is headed towards this direction, we have to, the biggest thing will be cost. Can we make them accessible to every individual that's out there? So if these devices continue to be at $900 per device or $400 or $500 per device, again, you're going to have a limited group of people having access to them. Louise, I just wanted to say one thing just prior to the last question that I think is that I feel is very important. Now, I believe in empowering patients. I think that's the technology should empower them. It shouldn't really enslave them. And so what I mean by that is that so you can have these devices, but we also need to focus on health literacy among the patient population. So just having an app or just having a device and being able to read the numbers doesn't necessarily equate with you understanding the medical problem itself. So if we do roll out these devices on a very large scale, or if patients use them very commercially, I would still encourage them to work with the healthcare professionals as they are viewing their own healthcare data. Otherwise, it would be no different than just me going up to Google, typing in, oh, I see a rash on my body, what disease do I have, you know, and then self-diagnosing myself. Now, I may very well get that diagnosis correctly, but I think it, you know, it would help to validate, right? And that was one of the first questions that you started with, like a validation part, who's doing it, right? So I think we should just keep that in the back of our minds when it comes to technologies and patient empowerment and even healthcare inequities.
I agree. Thank you for raising that. I think it's an important issue as well and very related. Zisis, what was your thoughts regarding technology, the relationship between technology availability and health inequality?
It's a very well. I would echo what Arif said, in that there is a lot of complexity in this question. I think a lot of the technology has become immediately available, especially in low middle income settings, and has allowed for information to flow a lot quicker than before. However, how that information is used, it hasn't been answered. So I might be in a place where I have a phone and I'm able to access different apps, but there is no linking between this app and the rest of the healthcare system, because sometimes is not even there.
That's right, yes. And John, would you like to tackle this? Have you got an answer for this very complex?
It's always a tricky one, isn't it? It's always the heart-sink question whenever you're sat on the stage and someone asks you about health inequality. I think the question for me is, does it make it worse? Because, you know, health equality is there, you know, whether we like it or not, quite sadly. And I think, you know, the answer is that providing the things that we've been discussing today are available in mainstream technologies, I think the answer probably is it doesn't make it worse, because people do make choices about what they spend their money on and what they do with their lives, and you know, people are attracted to these consumer electronics, and often they will go without other things in order to obtain such devices. I do, however, think though that as soon as these become device specific and are not within the device that you can buy in the high street and become critical to health and healthcare and well-being, then I think the thing would flip around and the healthcare equality would be widened as a result.
Yes, I mean, because one of the things too regarding the advantages of technology to help actually decrease the inequality, that's there as well. So, you know, some people have access to their own healthcare information, which as they should. However, there is still a huge percentage of the population, and in Australia, for instance, where I am, it is very unusual for people to have full access to their entire clinical healthcare record. We're just not there yet. Other places are more advanced than where we are. But, you know, it's very difficult to be able to say that we're trying to empower people to, you know, have access to be agents of their own lives when we don't even give them access to their health records. So certainly by digitising that information and making it available to people, that actually can help improve the inequalities that exist in terms of just having that access to information. Would you agree?
Yeah, absolutely. And you know, I don't want to particularly talk about the maturity standards, but we have tried to build in the patient engagement, personalised medical record, patient control of that record into all our standards. We really do perceive that having the patient as a co-producer, and the patient can only be a co-producer if they have the same level of information that the clinician or other people who are providing care has. You know, that only works when the data is digitized. And you know, when I speak to clinicians who are caring for people who have access to their own healthcare data, every single one of them describe the improved and enhanced consultation, because it just makes the whole conversation much more equal and balanced when the patient has had prior sight of the record before they go in to see the clinician.
Agree, yes. All right, I'm conscious of time, so I'm going to ask you guys for a quick comment on one question, and that is regarding leadership. John, you spoke about leadership at the beginning of your speech, and thank you for that contribution and the importance of compassionate leadership. So I will throw to John first, and the other two gentlemen, you can have a think about your response. Just a quick thought regarding the importance of leadership, especially when we are facing this global pandemic, which is just having impact on enormous, amounts of people and causing all sorts of hardship.
Yeah, thank you. I think I'd make two comments. The response to the pandemic has meant that care providers have had to collaborate across care settings, across social care, primary care, secondary care. And what that means is we require leaders who can manage all systems rather than leaders who can manage single organisations. And that requires a very different set of skills, attributes. So rather than the command and control, we need leaders who can look externally rather than internally. Leadership that is more suited to influence, more use of sandpaper and less use of the hammer. It does take a very different skill set to manage in such challenging times. And I think the second thing is about empowering others. Organisations or whole systems rarely survive with a centralised leadership strategy. It's got to be devolved. You've got to be comfortable with default decision making at the lowest possible level. And the old adage of having a leader in every seat is certainly what's been a prominent feature of the last 5 months.
Thank you for that feedback, John. So we are over time. I've just had a message from the organisers. So Zissis, I just throw to you if you have any final wrap up, and we'll finish this session. So that's all you'll hear from me. Thank you everybody for contributing. Zissis, did you have anything to say finally?
And just to say, it's been a fantastic session, really exciting talks. I enjoyed the observations from Arif about the wearable technologies, that we need to understand them first before being able to understand the data and what it tells us about the pandemic. And then the take of the more personalized taking of John about the leadership and how the experiences of his close family members have helped they understand the better relation between technology and the opportunities therein.
Great. All right. Well, thank you everyone for your contributions for this session. Really appreciate the time. Thank you for sharing your knowledge, and back to you in the main studio.
Thank you. Thank you.
Thank you all for a great session about the role of wellness technologies during pandemics. So now we will share with the audience 2 polling questions for our next session. The first question, on a scale from 1 to 5, how strongly do you agree with the role of telehealth applications in the fight against pandemics? For number 1, strongly disagree, 2, disagree, 3, neutral, 4, agree, and 5, strongly agree. You have 30 seconds. We will show the results in a bit, few seconds. So as we can see, the majority do agree with the role of telehealth applications in the fight against pandemics. The second question, in your view, what are the main challenges that face health and care workers to utilize telehealth solutions during COVID-19 crisis? You have 30 seconds to write your answers and we will collect your insights. Thank you. Now we will be diving into the topic of telehealth and its role in fighting pandemics. To do so, it's my pleasure to introduce the session chair, the Secretary General of the Saudi Commission for Health Specialties, Dr. Ayman Abdu. Welcome, Dr. Ayman. And the co-chair, professor and deputy director of digital health at the UCL Institute for Healthcare Engineering, Professor Anne Blandford. Welcome, Professor.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's a great pleasure and honor to share with you this afternoon this discussion on this very, very important and timely topic. You've heard discussions on epidemiology, on public health, on AI and other things, but although these issues are very important and very challenging, doing actual care is probably the most challenging and so is the one associated with the biggest opportunity. How do we deliver healthcare when there is a total lockdown, like in the beautiful city of one of our speakers, Melbourne, for example? How do we take care of patients who has the disease, but also patients who have regular follow-ups and regular healthcare visits and medications and diagnostics? If you put the hat of the patient, obviously there are so many challenges and worries and opportunities. If you put the hat of the healthcare provider, there are challenges and opportunities. And if you put the hat of the regulators, payers, entire system, there are opportunities and challenges. So around that, we're going to have a great discussion this afternoon. And it is a great, great honor for me to introduce the co-chair for the session, Professor Anne Blandford from the UK. Anne has a very interesting background of mathematics and artificial intelligence. She has a PhD in artificial intelligence, and she specializes in a very, very interesting thing that I actually never knew that there were people who do research on this issue, which is interaction between human and machine or human and computers. And she's actually a professor of human-computer interactions at University College in London. And she's also the deputy director for the UCL Institute of Healthcare. And just in the last seconds to introduce the session, I would like to read 3 lines from her biography, because that explains exactly what we're going to do in the next hour. She says that the question that motivates her most is that how can we design and deploy health technologies that really work for people rather than technologies that force us into undesirable modes of working, causes stress, or are rejected as not being fit for purpose. I think this captures exactly the essence of this session. So with that, I hand it over to you, Anne, to introduce the speakers. Thank you very much.
Thank you very much, Eamon, and welcome to everybody to this session. And I'm delighted to introduce our first speaker for this session, who is Dr. René Amalberti. René is Professor of Medicine and former scientific advisor for patient safety at Haute Autorité de Santé. My French isn't very good, sorry, René. He's also volunteer director of the Public Foundation for Safety Culture in the industry. During his career, Dr. Amalberti has held many senior positions in national and international organizations, bringing his expertise in medicine and human factors. He's published over 150 international papers and 12 books on system governance, human error, and system safety. His most recent book is Safer Healthcare, which he co-authored with Charles Vincent. You can download it for free from the Springer website, and I really recommend it, especially page 29. René, over to you.
Thank you, Anne. Good afternoon to everybody, maybe good morning. Sorry, I don't know what time is it exactly worldwide, but different times. Thank you for inviting me to comment on this difficult topic of medical shutdowns. Of course, the problem is not only the problem of the, the problem is not only the problem of the pandemic of the COVID. We have medical shutdown in various conditions, environmental disasters, wars, and not least probably also in a way isolated and deprived areas worldwide that have little or no medical support. What makes maybe more specific the COVID crisis is the idea of the quarantine and the mandatory isolation of the population for a long period of time. We shall come back on that a little bit later. So if we want to understand very quickly what occurs with medical shutdown, easy to understand, we have an interruption of the routine care for chronic patients. In practice, the healthcare system cannot sustain the uncontrolled outbreak. And especially in the COVID, the surge in patients requiring ICU admission has been totally overwhelming all countries. As I said before, the cities and countries are quarantined and government have instituted stronger containment measures, including strict self-isolation measures and major problems with emergencies. Well, it's just a summary to say that the medical access is made difficult or impossible. Doctors and nurses are missing. This is one of the characteristics of any shutdown. And this is due to a double mechanism. One is the number of demand, which is growing very quickly. And the other point is the growing lack of professional in the case of COVID infected by the disease, but the same with the war for other reasons. What we know from the literature is that the time scale is critical. After 2 weeks, the problem starts to become really big problems. After 3 months, the problems turns to really very, very complex problems with a lot of consequences for the medical for the medical consequences, but also for the political consequences. If we just try to capture the size of the problem, we have a number of visits to ambulatory care which declined by nearly 60%. This is shown on this picture from the Commonwealth Fund, but similar results have been obtained in many, many countries. So it's probably an average 60% of visits to ambulatory care disappearing. Another point is that we now have an estimate of 10% of additional collateral deaths of severe chronic and cancer non-COVID patients after 3 months of shutdown. And again, is a result that comes from different sources. But very recently, there were some papers in France and in UK telling that at least 30 to 40,000 people having a cancer have stopped any care during 3 months and are now in extreme danger for the purpose of their disease. Of course, this is also a problem of providers that are deferring elective and preventive visits, not just cancer, and this is true for all annual physicals. When possible, and this is the very core of this meeting, they are converting in-person visits to telemedicine visits, and that is good. But it is true also that patients are avoiding visits because they do not want to leave their home and risk exposure, and also influencing both provider and patient behavior are the evolving local and state recommendation restricting travel and non-essential services. If I just comment on the quarantine, the quarantine was introduced a long time ago in 12th century, but with Black Death, with leprosy, with probably also, certainly with plague. And recently we had a series of quarantine, also small quarantines or limited quarantines in China and Canada in 2003 with the SARS, and in many villages with the Ebola in Africa. And we have a fairly large literature on the results of quarantine, and it's a dramatic impact of medical shutdown for mental diseases. There's a lot of people really in trouble, and of course the more exposed people are the older, but also we see that the people aged 18 to 30 are overexposed to social media and tend to be more impacted at mental level by the quarantine. So and migrant also, the poor people. So we are in a situation where the shutdown is really creating a lot of problems for the population. Of course, we have the whole problems. When we opened the shutdown, the crisis highlights a number of inherent weaknesses in existing healthcare system. If you have a shortage in doctors and nurses before the pandemic or before the problem, of course, that will become a huge problem with the pandemic. And also, we have a series of new problems coming. I suspect that these problems have been developed in many talks before, but it's quite important to say again that in most countries, we have terrible problems with these essential resources needed to tackle the pandemic, with the lack of respirators. So the shutdown is not just a human shutdown, it's also a technical shutdown. We have, as I said before, clinical staff becoming infected, resulting in periods of quarantine, some clinical staff paying the highest possible price, the loss of their life. We had in many countries figures about 15 to 20% of the professionals off during a period of time because they had the COVID or they had the suspicion of problems. They could be off for 1 day or for 2 days, for 15 days or to 3 months. But the accumulation of people off was really terrible for the shutdown and increasing very quickly the importance of medical shutdown. We have growing patient emotional problems associated with this crisis. And just to say that it's quite interesting to see, we have several now reports from Italy with the first COVID patients they had, and the crisis during the first, second, and week. And they say very clearly that they had terrible problems with patients willing to go to the hospital. And we have similar results from Asia, from Chinese paper and from other countries in Asia, telling that people are so emotional that they come and make an additional problem for the hospitals and for doctors because they fear having the COVID. Of course, we have new form of stress for doctors, and here we are introducing the solution and the limitation of the solution, because nonverbal communication, which are at the core of the telehealth, or most of the telehealth as it was used during the COVID, as well as physical examination, are essential tools to practice. The crisis imposed to make decisions without seeing the patient, and sometimes even without knowing him or her, and that has turned to terrible anxiety for doctors. And last but not least, everybody knows that there is a terrible uncertainty of the situation at internet, and that's part of the risk in the medical shutdown. Very little knowledge about the disease caused by the virus, and the professionals as well as patients were unable to distinguish accurately clinically between those with a common cold or bronchitis and those with a case of COVID. And no idea how long this pandemic and the economic and social crisis will last. It will last, and this is always true. So it's really a big difficulty in managing such a situation. Sorry. Sorry. Okay. If we turn to the coping strategies for managing the situation, the first point worldwide is really the demonstration of the medical profession's power to adapt, evolve, and thrive, even in these times of unprecedented crisis. There's an incredible solidarity and creativity, and the hospital reorganizing at an impressive pace by creating new wards for infectious disease and intensive care, and that is true in all countries, including the poorer. The family medicine also is put at the center of the healthcare system, even among countries with a healthcare system that traditionally has been hospital-centered. And that is also very important, because we see that in such down episode, family medicine is very central. That's the level for triage, that's the level for giving care and protecting people who are not only patients with disease like the COVID, but also patients that are very anxious, that are isolated, that are in situation where the domestic violence is increasing. And we had terrible figures about domestic violence during this period of shutdown. So the family medicine and every solution that makes people listening to problems at home are extremely valuable in this situation. Of course, national coordination centers have been established. It's true also that the social media have been really contributive to increase the emotion, but to share the emotion and give people some solutions, or orient people for some solutions. There's a lot of wrong information on social medias, but there's also some important mechanism for using this social media as tools for breaking the shutdown. It was also a good opportunity to for impacting and reorganizing teamwork this shutdown, and this has been quite effective in many cases. And of course, new guidelines have been developed by Society for Family Medicine and by professional expert group at a speed unthinkable in normal times. And this is really something applying to telehealth. If you see another results of this use of telehealth during the COVID-19 crisis and the shutdown, what you see, and it comes from a US paper, is clearly three curves. The first curve is the immediate reaction of people or outpatients calling and using telehealth for reinsurance. Then you have the red curve with inpatient using telehealth with the doctors in sync with the severity of the disease and the test of symptoms. And you see a little bit later the green curve, which is a very important curve since I commented on. It's the curve related to patients that have chronic disease different from the COVID and that have postponed their care for weeks, for some, for months, for others, with a risk, and that start again using telehealth after this period of time and increasing very rapidly their visit to try to take into account this long period of no care. So if we summarize the most utilized areas of telehealth in times of such a shutdown, of course, we have the patient consultation, including drug delivery in sync with pharmacists. This is very, very important because if you just do consultation, it's not enough for most. So you really need to have a system that can deliver drug by telephone or with a protocol for confidentiality and for being certain that the doctor is the person who orders the drug. Of course, we have many patients monitored at home, especially inpatients and outpatients, inpatients that were discharged from the hospital and then at home during a period of time that are post-critical and that need follow-up monitoring, and that was done with telehealth. I mentioned the social media and the medical information sharing in time of crisis, just to say that we have probably 3 billion people using social media, and despite the very risk of propagating false information, it is a fantastic tool and many good initiatives were created during this crisis to propagate good information and reinsurance to people for the COVID and what to do and how to share vision of the COVID. And this was very well done in many websites. It's quite important during shutdown to imagine that the medical video conferencing is almost as important as patient consultation. And this is not usually seen as that. It's less considered than patient consultation as a very important item of telehealth. But medical video conferencing is very central. Imagine a country, whatever the country in the world, we have big hospitals, we have also remote hospitals, rural hospitals, small entities that are missing educated specialists in or intensivists. And in that case of COVID, where we needed beds and knowledgeable people in many areas, medical settings, it was a huge chance to get this video conferencing for people who are less knowledgeable, calling their colleague in big hospitals to get information and strategy. Not mentioning at end the mobile telehealth, which is now so important for communicating with all patients. So we learned a lot on teleconsultation during the COVID-19 crisis and the medical shutdown. We learned about the IT infrastructure, the organizational routine and workflows, a lot of actions and strategies that were imagined before have changed with the practicality of doing it every day. Because before, and that will be my conclusion on the next slide, before we were expecting a lot from telehealth, but we were doing very little. And we have totally changed the way we were thinking about these strategies, doing that every day. And this is really one of the major points. And I just want to conclude with decided that telehealth is a solution to medical access and to medical shutdown. And it's not new by itself. That started in the 40s and was promoted in 2000 by the WHO and required by law in many nations as one of the best solutions for coping with the big changes occurring in healthcare. We have massive aging, much more patients at home worldwide, critical medical demography, so we have more patients and less doctors and nurses in many countries, and we have more and more isolated areas. So telehealth has been recognized as safe and efficient enough, and has been recognized as a key solution for coping with this future. But conditions for generalization were not met before the COVID-19. Poor quality of communication. It was also said that it was less effective to proceed by telehealth than to proceed by direct consultation. There was a very big concern about the digital divide and the internet. Also for the professionals about the payment share, because in many countries, just asking by telephone some information to the doctor was not paid. So it was not something recognized as a solution for the future, and the confidentiality was still a problem. So it's true that we have probably imagined a new future with the COVID and this shutdown, because we have developed a solution that have progressively demonstrated that it is safe enough, it's good quality. We have solved in many countries the payment share, and we are now paying for people, and that's the final point that I wanted to say. Medical shutdown, big crisis, but a big chance for telehealth to imagine new solutions. Thank you for listening.
Thank you. Sorry, I can't tell whether it's just me or whether Dr. Abdo is returning as well. Maybe it's just me, in which case I will transition to our next speaker. So our next speaker will be familiar to those of you who were in the previous session, because she chaired that. So we're making her work double hard. Dr. Louise Schaper is Chief Executive Officer at the Australasian Institute of Digital Health. And she's based in Melbourne, which of course is right now one of the notorious areas for its local lockdown at this moment. She has a background as an occupational therapist and a PhD in technology acceptance among health professionals. Amongst her many achievements, she was recently elected to a fellowship of the International Academy of Health Sciences Informatics. Dr. Schaper is a passionate advocate for the transformation of healthcare enabled by technology. For example, she hosts the popular Dissecting Digital Health podcast and describes herself as having the coolest job, though I might disagree because I think I have that too. So I'd like to hand over now to Dr. Louise Schaper for our next talk. Thank you.
Hi, I'm Louise Schaper. Firstly, I'd like to say thank you to Dr. Bandar Al-Kanawi, who invited me here today, and thank you so much for the invitation. I'd also like to acknowledge the traditional owners of the lands in which we meet today and pay my respects to elders past, present, and emerging. Today, I'm speaking to you from my apartment here in Melbourne in Australia, and this is Warren-Digi land. I'd also like to pay my final acknowledgement to you. Yeah, you and the 90,000 odd friends that you brought with you today. This is probably one of the, if not the biggest digital health conference ever held on the planet, and you are a part of it, which is pretty exciting. And, you know, it's so great to see such a massive community get together today to discuss all things digital health, because it's only by collaborating and working together keeping in mind that the reason that we do what we do is all about the patient. It's about providing high quality patient care and improving health outcomes, whether that be for the individual or on a population level. And by collaborating and never losing sight of why we do what we do, we will succeed. Now, it's an honour to speak with you today, and I look forward to your questions at the end of the session. So I work for the Australasian Institute of Digital Health, and we are based in Melbourne. And basically, we're a non-profit membership organisation, and our business is all about leading and supporting those who are delivering the future of healthcare. Now, last year, we released this report, and I wanted to bring it to your attention. So thanks to my colleague, David Rowlands, who authored this. What is digital health and why does it matter? You're probably thinking, and maybe you do yourself, you use the terms interchangeably with digital health, e-health, health IT. Is there a difference? Does it really matter? I say yes, that it does matter. Not that I want to get into academic semantic debates on language today. However, if we look at the era of digital health, we look at what's come before, and effectively we're looking at, in the past, dating back to the 50s, we had computerized IT-based systems that were applied to healthcare. At first, they were not specifically built for health, but they were applied to healthcare. And we looked at technologies that were available, used in other industries, other sectors. How can we make use of these in healthcare? And then it progressed to quite recently, actually, where we were looking at purpose-built applications specifically designed for healthcare, whether that be in your GP clinic or at a hospital setting. Community care, the whole bit. So how is digital health different to these waves that have come before? And it is very different, because now what we're talking about when we talk about digital health, it's really about the application of healthcare in a digital world. So think about it, how does healthcare need to exist in our world that is becoming increasingly digital? I've got 5 computers in front of me. If I include the one that I'm wearing, you've probably at least got 2. You know, I'm coming at you virtually. Our world is increasingly being digital. It is infiltrating every aspect of our lives. Not for everybody, but for the majority that is happening. So how does healthcare need to reinvent itself? How does it need to exist? How does it need to be? How does it need to transform in this digital world? This digital health era is characterised by 7 shifts. So we're looking at changes for citizens and consumers, centricity. We've got new entrants, new players into the system. We've got convergence happening everywhere. So that's industry convergence as well as role convergence. And we've got the origin of data that's changing. Analytics and algorithms are going to just skyrocket in terms of their importance. And it's also broader than health. And finally, those shifts result in changes to all sorts of things. And I'll leave you to read the slides for yourself rather than read them. But we're looking at a massive disruption to healthcare, and many of you are experiencing that and have been experiencing it, and hopefully are leading that charge as well. So in regards to what's happening right now with the COVID pandemic is, of course, you can't escape telehealth. Telehealth, telehealth, telehealth. A lot of countries used to refer to it as telemedicine. It seems everyone's adopting telehealth now. So here's an article from April from Arab News saying that here in Saudi Arabia, telemedicine is on the rise amidst the pandemic. Well, that is actually a trend that's being replicated across the globe, of course. Globally, we have just seen that telehealth has been ignited in response to the pandemic. In an effort to flatten the curve and keep people healthy, we've turned to telehealth to keep people out of the healthcare system as much as possible and to keep them safe. Now, we can continue delivering care. Many healthcare professionals are now delivering care remotely. And that's not just doctors and nurses and hospitals, it's happening in the community. Midwifery, physiotherapists. My partner saw an osteopath that he'd never met before. He saw him via telehealth to fix his shoulder. And good on you, Declan. Thumbs up to you. You really helped. Now, whether it's India, Middle East, Saudi Arabia, Australia, the United Kingdom, the United States, in all aspects of our globe, regulations and impediments have been lifted and significant financial investment have been made by governments and the healthcare sector to give telehealth its moment in the sun. Now, to say that there is a lot of money being invested in digital health and telehealth this year is pretty much a massive understatement. Investors are convinced that a preference in healthcare to maintain the status quo just doesn't exist any longer. And now with that barrier removed, they're expecting to see new ways of delivering healthcare will become our post-COVID norm. The graph, and thanks to Rock Health for that, $5.4 billion in venture capital went into digital health in the first 6 months of this year. And that's just in the United States, and it is the biggest amount they've ever seen yet. And last week, after announcing an 85% jump in revenue, the US telehealth giant Teladoc announced a merger with Livongo to the tune of $18.5 billion. And if that doesn't strike you as crazy enough, a 3-year-old startup called Row just raised $200 million United States with a $1.5 billion valuation to transform itself from a company that was treating erectile dysfunction until recently to a telemedicine service. Now, just in case your eyes are dazzled with all of this, it's worthwhile noting that telehealth is not new. In fact, the concept of a radio doctor was predicted almost 100 years ago, and you can find these images on the internet. I think they're wonderful. They're very cool. Now, when all this happened in Australia, our government was fond of saying that they enabled 10 years of innovation to take place in 10 days. And other countries have said they've done 5 years of innovation in 5 days or 5 weeks. And telehealth has actually been around though since the 1950s, and it has technically been very feasible and not commonplace everywhere, that's for sure, but it has been happening for the last 20 years. So the difference now though, it's scale. Outside of the healthcare system, how many people would have heard about or let alone understood what telehealth was prior to the pandemic? Not you, of course, and your 90,000 friends, but you know, you're probably now not the only one in your family who is talking about telehealth. And if you're like me, your family finally has an understanding of what it is you do, or at least they think they do. Many healthcare systems have seen a dramatic rise in telehealth, and the majority of people are actually first-time users from the clinician side as well as the patient side. Changes that would normally take months or years, or in a nod to those who have been advocating for telehealth for a very long time, decades, have occurred within days to weeks. This has led to a chorus of voices echoing for telehealth. It's here to stay. So will this change be permanent? And if so, to what degree? Will our healthcare systems and the mode of delivery of care be forever changed and reflected on as before COVID, or before 2020, before COVID-19, and after COVID-19? Now, one thing is for sure, and that is that we are undergoing a paradigm shift. The healthcare sector has shown that when motivated by patient care, we're innovative, we're creative, like we'll get it done. And I mean, the healthcare system and everybody who works in it is just to be congratulated for the amount of innovation they have managed to achieve in a short period of time while dealing with a pandemic. So healthcare is changing and evolving. Healthcare, of course, that was once delivered in the exclusive buildings of doctors' offices and hospitals will increasingly reach us, consumers, over a phone, over a video, over an app, a retail clinic, in people's homes and in their communities. So how do we prepare the workforce not to be passive recipients of change, but to be architects of their own destiny? Like this cartoon, I'll leave it with you. Now, with this rapid upscale of telehealth, it has shone a light on the fact that we need to do a lot better at preparing our health workforces for more digital ways of working. The majority of clinicians haven't really used telehealth before, and what's happening now has left many feeling quite overwhelmed and burdened with the pressure of using a modality through which to deliver care that they have had very little prior experience with. But as I said earlier, despite this, they did prevail, they have prevailed. Although I would say that, not a little bit dissimilar to this cartoon, that the majority of telehealth consultations globally are actually being conducted via the phone, not via video. I think it's fairly safe to state that healthcare delivery in the post-pandemic era will not be as we know it today, or certainly as we knew it 6 months ago. If we accept the premise that telehealth is here to stay, then we have to get to work. We've got a lot of innovation to do. We have to design systems of care and delivery that prioritise the patient and which support clinicians, not just to navigate their way through this system, but to lead the effort. I believe that there are two universal truths that we can expect. Number one, and first, we know that the approach will not be universal. It will vary with different preferences for technology use based on the technology availability and access, patient profile, personal preference, and a raft of different factors. And secondly, that the business models of healthcare will need to be rewritten. And this is pretty much universal. So every single healthcare organisation is going to have to rewrite their business plan. What will we see? Well, firstly, we're going to see a virtual first approach, where a virtual triage session will determine if a face-to-face appointment is required. Secondly, we will see clinicians and patients, at least I hope for this one, clinicians and patients working collaboratively to decide together on the best modes of healthcare delivery that best meets the patient's needs and their expectations. Also, I predict that it'll bring back the idea of a house call, where virtual care subsumes the traditional remote consultation to be combined with remote monitoring, coupled with periodic in-person visits from clinicians and carers. And fourthly, we will see the rise of specialist virtual-only providers. And that has certainly been very controversial here in Australia, and it probably has in your part of the globe as well. So what do we need to do to deliver healthcare in the post-pandemic era? We need data. Firstly, we need good quality, highly reliable, available in real-time data. The sources of data. The data will come from increasingly from multiple sources. More and more, it's going to be generated outside of traditional healthcare systems, from sensors in our environments, on our phones, and of course from the patient or citizen. Thirdly, data interpretation. So here is where we will see an increased role for artificial intelligence to help us manage all of that data and to ensure it is utilised effectively. Fourthly, standards, data and technology standards. It's about time, I think, as the healthcare sector, that we stood up and said that we will no longer accept technologies that aren't built to interoperable standards, that enables data to be captured and flow to where it needs to be, with appropriate privacy and security protocols in place, of course. The data needs to flow to where it needs to be to deliver high quality of care to individuals and for populations. And a significant challenge that we have is the digital divide. We would like to think that in this day and age, we could deliver a healthcare system and a technology that's backing up that healthcare system where no person is left behind. Unfortunately, that is far from actualities in most places. Here's a couple of articles just from the last couple of weeks that have been published, a study from America and another one in the UK, pointing to the surge in telemedicine and telehealth throughout these countries is unfortunately leading to an inequity in access for people who don't have access to those technologies. We cannot turn a blind eye to this problem. We need to face it. We need to do something about it, and we can. Healthcare delivery in the post-pandemic era will actually also have workforce challenges, and it's the workforce that is super important. It is often neglected. I know, like, you would have your own experiences where you feel supported, and other things you will find that you don't feel as supported. On a large scale though, we have a lot of room for improvement. Upskilling the workforce in digital health does not mean that we take the majority of the healthcare sector, we put them in a room and we train them on how to use a piece of IT equipment. We need to do way better than that. Firstly, we need specialists that specialise in health informatics and digital health. We need to increase the digital health literacy across all clinical professions. So if you think about that, it's like if you're a surgeon or if you're a physiotherapist, I don't want to be a specialist in digital health, that's fine. I just want to be a great clinician. So it's the year 2020, it's the year 2021, in the future. What is it that I need to know about digital health to be the very best clinician that I can be? And thirdly, we need to define and set standards for professional practice and professional practice guidelines. Fourthly, skills development and validation. We need tailored education, we need certification programs and continuing professional development programs that provide professional career pathways and professional recognition for all. We need accreditation and proper global accreditation of our education programs, and we need to really monitor and give feedback to the healthcare organisations regarding their digital maturity. Finally, when it comes to workforce development, we need to make sure that we're not going to allow technology to be a replacement or a solution for understaffing and resource constraint issues. It's not a panacea either. Technology has to be seen, and it very squarely sits in the healthcare system as being a tool in our toolbox. It's an enabler of healthcare. And at the moment, we aren't utilising it anywhere near as much as we can. There's a million other topics we could talk about, like artificial intelligence more, digital humans, all sorts of things that will expand our current landscape of telehealth and digital health. But we always have to make sure that when we talk about what we do, it is all about putting the patient first, maximising the outcomes for the patient, maximising the data utility to ensure that those outcomes are maximised for patients and for a population as well. Now, thank you very much for your time today. As I said, it's been an absolute pleasure to be here with you today. I look forward to your questions, and I can see that they have been flooding through. Thank you very much, and I look forward to speaking with you soon. Thank you.
So thank you so much for that, Louise. That was also fascinating. Unfortunately, because we're running so far behind time, we've been advised that there isn't going to be a panel session with this at the end of this one. Hopefully the questions will be used to inform the ongoing thinking, but regretfully we have to kind of catch up a bit of time. So I'm just going to try to draw out some of the common themes from the last two presentations. And there have been some very strong common themes. I think you both talked about the consequences of the shutdown, both negative, the stresses, the strains, that having to rethink things very quickly, but also the much more positive side of that, the creativity, the solidarity, the innovations that have come from this unexpected or ill-prepared need to really transform healthcare delivery and to deal with things in new ways. We've talked about the changing healthcare systems and emphasised the need for interoperable standards that will actually make telehealth work for the citizens and also for the professionals who are delivering care. Of course, we've needed to remove regulations and restrictions and to deal with that creativity, and maybe we'll have to find a new balance between regulation that keeps people safe and creativity that makes new things happen. And that'll be part of the new normal and the way that things go forward for telehealth in the coming years. Had I had a chance to ask a question, I would have wanted to ask, what will telehealth be like 5 years from now, given how much has transformed in the last 5 months even? We're expecting more healthcare to happen at home, but recognise that that needs to be inclusive and make sure that citizens and migrants indeed don't get left behind and don't get excluded due to their circumstances. There's a need for good data and for skills development, and I would argue that that is for both professionals and patients, population, the rest of us. So on that note, I'm going to hand back to Eamon to close this session. Thank you to the speakers and to the audience, and I'm really sorry that we've had to cut out the panel session today.
Okay, thank you. Thank you very much, Anne, for this great sum up. I've had like 10 questions in my mind, and I'm sure there are so many questions by the audience, but it's unfortunate that we have to close. And I have to mention that it's not our fault, it's an accumulative over time over the previous sessions. So I'd like to thank you very much, Anne, for co-chairing the session. I'd like to thank the speakers for a fantastic insights on this very important topic. And unfortunately, we have to close it now, hoping to see you again, hopefully in Riyadh, and we'll have further talks. Thank you very much.
Thank you.
Thank you all for such a rich discussion on telehealth and its role in fighting pandemics. Before we start our session, artificial intelligence and robotic process automation, we will share with the audience 2 polling questions. The first question: in your view, do you think that artificial intelligence will play a major role in the fight against future pandemics? 1, yes. 2, no. 3, I don't know. You have 30 seconds to answer. We will have the results appearing in seconds. Interesting. So we can see the majority of the audience answered yes when asked about artificial intelligence playing a major role in the fight against future pandemics. Question number 2. On a scale from 1 to 5, 1 being the lowest, 5 being the highest, how do you think, or how do you rank the effectiveness of artificial intelligence applications in the fight against pandemics? You have from 1 to 5. We're going to have the results appearing in a bit. Numbers are somehow close, but the majority of the audience chose number 4 when asked about the ranking of the effectiveness of artificial intelligence applications in the fight against pandemics. Now we'll discuss the topic of artificial intelligence and robotic process automation more. And to do so, it's my pleasure to introduce the session chair, the Chief Executive of the Digital Health and Care Institute, Professor George Crooks. Welcome, Professor.
Great. Thank you very much indeed. Over the next hour, with the help of my 2 colleagues, we'll seek to not only inform you of the role that digital technology development with a focus on artificial intelligence and advanced analytics and the role it has played in supporting governments, healthcare systems, delivery organisations and, in fact, individual citizens in rising to the challenges presented to us all by the current pandemic. But we will also seek to challenge you and to encourage you to collaborate with each other in the future so that we as a global community can ensure we continue to innovate, design and deploy digital tools and services that will support the future delivery of safe, effective and sustainable health and care services that not only support current and future pandemic management, but can also underpin the continuing evolution of health and care services that are fit for the future, wherever you are in the world. As you'll hear from our speakers, these words are very easy to say, but certainly more difficult to deliver. We are on a journey and we're certainly not at the finish line, but we've learned a lot so far and we're still learning. So let's hear from our two speakers. We'll hear from both of them first, and then we'll move to a general discussion, and hopefully we may be able to take one or two questions. So, talking about the role of artificial intelligence in fighting current and future pandemics, our first speaker is Dr. Essam Al-Wagait, Director of the National Information Centre for the Kingdom of Saudi Arabia. Dr. Essam, would you please give your presentation?
أقعد على كرسي أفضل ولا؟ Thank you very much, Professor. Ladies and gentlemen, everyone who's watching us through the internet superhighway, good afternoon or good morning or good evening, depending on what time zone you live in. First of all, I'd like to thank the Ministry of National Guard, the Health Affairs, for organizing such an amazing summit. I feel honored and at the same time humbled to be chosen to discuss or to speak at this summit. The title of my presentation is The Role of AI in Fighting Current and Future Pandemics. The presentation, I'll have 4 parts. I'll give a brief introduction. Then we'll highlight some of the areas where AI played a role in combating COVID-19. And then we will look at what the future look like when it comes to AI. How can we unlock the potential of AI for future epidemics or pandemics? And finally, we'll look at some of the challenges that hinder realizing the full potential of AI. So when we mention AI, we always think of it as an exotic term. You know, people think AI, they think about sci-fi movies. They don't think it's a reality or something that we experience and we live today. I want to just give 2 examples. 6,000 miles away and 9 days before the World Health Organization even mentioned COVID-19, AI was able to detect and flag the existence of COVID-19. So we have a company called Blue Dot. It's located in Canada. And also there was Health Map, which is in Boston. They made the similar observation. They noticed an increase in the number of pneumonia cases in Wuhan, China. And that was abnormal activity for them. The AI algorithm detected it and flagged it as an abnormal activity. Had we had looked at it, we would have had 9 days head start with AI. So fighting pandemics, we raise the hat for our heroes, our health staff, health professionals who risks their lives and spare their times just to make people feel better and help people in such difficult times. However, in the back end, we have other people who help those heroes. We have authorities, we have medical researchers, data scientists, statisticians who develop and use technology and AI to facilitate and improve and help the health professionals do their job in a proper and effective way. They say that if you want to predict the future, you should look at the past. Just looking back 2 decades ago in this century, we have had 9 epidemics and pandemics. In 2009, we have H1N1, and in 2020, we have COVID-19. I show this slide just to say and to show that, when we talk about COVID-19, we should not talk about it in isolation. We should look at it as something that we learn from, but this is a sad reality that we may have something similar in the future. And it's very important when you talk about pandemics that we don't need to deal with them in isolation. We don't need to deal with each one of them in a separate way. So we're talking in this presentation, I'll give some examples and some ideas how AI helps with COVID-19. However, we should not lose focus. We should, when we look for a solution, we should develop a holistic approach. We should develop something that could help us with any kind of pandemics. So looking at the current pandemic, the COVID-19, how did AI help? I categorize that under 5 major categories. So we have prediction models, we have contact tracing, we have medicine development, patient care, diagnostics, and examinations. And I'll explain each of them, and then I'll show some of the examples, and there are many examples around the world. When it comes to prediction models, we need to develop those models to help decision-making processes. So the governments and decision makers, they need to make important decisions and timely decisions in these pandemics. And those decisions depend on what's going to happen. If you don't have an accurate and effective prediction models, then you cannot make such decisions. And if you have poor models, then you'll make poor decisions. I'm talking about, for example, how to allocate health professionals, how to distribute resources, talking about logistics and so on. When it comes to contact tracing, this is a very important factor when it comes to dealing with pandemics. Pandemics by nature spread through people by being in touch or in contact with each other. So to be able to effectively manage those pandemics, you need to understand and to manage effectively the contact between people. And this is where contact tracing comes into place. You need to understand who needs what, who, and then how, and to be able to effectively limit unneeded interactions. When it comes to medicine development, of course, I'm holding my breath. Everyone else is holding their breath. We're waiting for the news that, you know, an effective vaccine is being developed. AI plays a huge role in the development of such vaccines. Patient care, of course, by nature, pandemics, you have a lot of people who are in need of medical help. And to do that effectively, you must rely on technology. And AI and technology play a huge role in that, and I'll show some examples. And finally, diagnostics and examination. Of course, this is also an important factor. It will help contain pandemics if you are able to detect people or potential patients, and by that eliminating further patients with viruses. So for the predictions models, for example, in Saudi Arabia, we have developed what we call COVID-19 index. So this model basically outlines how is this virus is going to spread, in which areas, and how, and the amount and number of people who will be infected. Of course, this is a model that utilizes statistics and AI to help decision makers to develop and make these important decisions. For example, we would like to understand how many people will need medical help in that area. How many health professionals should I allocate? How many kinds of medicines that I need to buy for this amount of time? You cannot wait for things to happen and then make decisions. You need to be proactive in a sense. So to do the proper planning, you need to have a proper and effective prediction model. Of course, we're not the only ones who are doing it. Like, for example, the United States, they developed such a model, and they anticipated what is going to happen if you do not quarantine people, or if you do not have curfews. And they plotted different scenarios, and they got different results for different scenarios. And based on those numbers, decision makers are able to do some evidence-based decisions. When it comes to contact tracing, of course, this is a very important factor. We always hear the term flatten the curve during this pandemic. This happens by eliminating the spread of the virus, and eliminating the spread of the virus always goes back to the contact tracing. What we have noticed that, countries that were effective in controlling the spread of the virus relied heavily on technology. In Saudi Arabia, we developed 2 apps. One is called Tawakkalna, which basically made people's lives easier during such difficult times. It was managed to help people obtain permissions during curfew times. It was provided some information about some information related to health and healthcare. We also developed an app called Tabaud, which relies on Apple's and Google's exposure notification APIs, and among other countries. So that app will allow you, once you download it, to be able to know when you have been in close contact with someone who was infected. So the way it works, the app utilizes the Bluetooth in the phone to detect when you are in close contact with a person and how long the exposure was. And based on that, if someone gets infected, you will be notified that you have been exposed to a person who was infected. Of course, the app was developed, taking into account the privacy of the users. Of course, other countries developed similar applications. For example, in the United States, we have COVID Watch. When it comes to medicine development, again, we're waiting for the good news any time of the day right now. I believe yesterday, Russia, they announced that they have developed a vaccine. I believe there is work also in Harvard, human immunoeconomics initiatives, and also in benevolent AI and other countries as well. They're working on developing the vaccine. The life cycle of the development of the vaccine usually is long, and we believe that technology and AI could cut this life cycle short by obtaining better results, by providing better analysis for the prospective vaccines. When it comes to patient care, again, with pandemics, as I mentioned at the beginning, the health professionals, they risk their lives every day by providing help for people who need it. So we would like to use technology to make their jobs easier. And we believe that technology played a huge role in patient care, whether in the context of COVID-19 or in general. For example, in the United States, Emerald developed and used Internet of Things to enable health professionals to get the information from the patients without being physically there. So you get the vitals, you get the movement and so on of the patients, and you were able to monitor them without being exposed to any health risks that relate to that. Also in the United Kingdom, they developed a way that they could diagnose emerging coronavirus patients through X-rays. And for diagnostics and examination, again, this is a very important issue when it comes to dealing with pandemics. You need to screen and to discover potential patients. In the United States, they are working on something called Cuff Against COVID. Basically, what it does, it's utilizing AI technologies to discover the potential COVID-19 patients through the sound of their coughs. So applying machine learning to different sounds of coughs, and then developing a way to be able to judge, based on the sound of the cough, whether that person is going to be a COVID-19 patient or not. Also in China, they developed remote diagnostics where they have cameras with heat sensors, and when someone passes, that camera will analyze the heat signature of that person, and it uses AI to with an accuracy of 0.3 degree to be able to flag if that person is a potential COVID-19 patient or not. So these are the different areas. Our team at SDAIA, they did a small analysis, and they wanted to see how effective AI in the current pandemic. So again, as I mentioned at the beginning, and I believe that our audience and their survey, in the survey just before this lecture, I think they hit the nail on the head in their estimations or in their guess of how effective AI is. We have 5 areas. In some areas, we notice that AI is doing a good job, but in some other areas, we believe there is a huge room for improvement. Again, even if the percentage is 80% or 70%, this is a high percentage. However, we hope in the future that this percentage is going to be much, much, much higher. When it comes to prediction, of course, there is an issue of lack of proper and good quality data. So the prediction models, they provide you with some insights. However, they are not as accurate as we wish. And sometimes they are affected by the short period of time that this virus has been there. When it comes to contact tracing, technology could play a huge role. However, we face some difficulties when it comes to legislations or sometimes with the collaboration of people, using that technology. So technology is there. However, if you don't use it, then it's not going to be effective. Medicine development, we believe there's a huge potential in that. However, it's not technology reliant as it is for other fields and other disciplines. Patient care and diagnostics and examination, the percentage is up there. However, we're hoping in the near future that this percentage will go much higher. So as I mentioned, AI is doing and helping us fight the pandemic. However, we're not realizing the full potential of AI. There are two main reasons, and I'm going to explain that also in the next slides. The first reason is that we're being reactive and not proactive. And just to put it in simple words, being reactive, basically when the pandemic happens, that's when we decide to deal with it. And that's when we decide to act upon it. But have we had something similar or even better than the example of Blue Dot? Then we'll be able to spot the pandemics even before they become pandemics and deal with them accordingly. And the second issue is that the efforts in dealing with those pandemics are not complementary. And I mean by that is that everyone is trying to do their best. However, they're working in silos. One of the largest issues, and I'm going to talk about them in the next few slides, is the issue of data sets that are incomplete. Imagine if we had everyone collaborating and sharing data sets. With that, we'll have a better data set that is complete and with a good quality. Imagine what would AI algorithms do with that. So for the future, learning from the past, we believe that in the future we could improve and we could capitalize more and unlock the full potential of AI if we do three things. First of all, we need to be proactive. And by that, I mean digital surveillance. We need to be able to have systems that are always looking for abnormalities, always looking for different patterns that will be the initial spark of a pandemic. The second thing is utilizing the technology in the contact tracing. We believe that technology could play a huge role in eliminating the spread of the virus if applied properly. Right now, technology is so cheap. The cell phone that I have in my pocket is more powerful than the computer I had probably 10 years ago. And the technology is advancing so fast. Sensors are getting cheaper and smaller and more effective. If we use that, we'll have more data to feed in our systems and more data to enable us to control and limit the spread of the viruses. And also, if we do the two things, then health professionals, the organizations, the governments will have more time, more resources, more budgets to allocate for the vaccine development. And with that, we can cut the life cycle of developing vaccines a lot shorter. And we will also have more data to feed into the development of the vaccines. So this is what it's going to look like. So this is the optimistic, what the future look like, basically, if we had, and God forbid, we hope that we don't have any future pandemics, but for the reality is that this is something that's probably going to happen. So what's going to happen is that you need to have an always-on digital surveillance. You need to have systems that monitors the data from different hospitals around the world and labs, and to be able to spot if there is an abnormality or something that is out of the ordinary. And that's where the gray dot on the left is. That's when you have the initial rise of the number of cases. That's when you understand that you are facing something that is new, something that you need to watch out for. Once that happens, then immediately you need to apply what you have with the contact tracing and isolation. You need to apply those technologies, and then you need to enable automatic sample collections. Those two things, first of all, will allow you to prevent the spread by eliminating the future or potential patients, and it will also allow you to obtain and collect more data that you will utilize in the prediction models as well in the development of the vaccine. So with that continuous effort, with the more data that you get, the vaccine development life cycle will be cut shorter until hopefully we get to that green dot. That's when you have an effective and working vaccine. And that's when you basically deploy that vaccine, and then the chart and the number will go lower until we have 0 cases. If you notice something in that optimistic future prediction is that the curve is almost flat. It's increasing, but it's not exponentially increasing. And that, I believe, is the proper way, and that is the effective way of dealing with pandemics. Once you control the number of patients, where you control the spread of those, whether viruses, whatever they are, to minimum number, and then deal with them in a shorter period of time. So that was a glimpse on what we have done currently and what AI is doing currently and what it would look like in the future. However, I don't want to paint a very optimistic picture. We do have some challenges, and those challenges could limit us utilizing and capitalizing on AI. The first one is the processing capability. Let's face it, as I mentioned before, technology is advancing faster than ever. We have faster processing capabilities, but they are not as fast as we would hope. AI and data, they go hand in hand. Usually when we discuss or talk about AI, we're talking about processing a very large amount of data, big data. And that's where AI excels, because it could spot patterns that the human eye could not spot. So the processing capabilities, what used to take months before, right now takes weeks or maybe days. However, we hope that it would take maybe hours or less, so that we could conduct more experiments in a very short period of time and deal with pandemics in a much faster way. The other part is data, and that's a twofold. So data, you have the issue of incompleteness, and you have the issue of quality. The issue of incompleteness is that, as I mentioned before, different government, different organizations, they work in silos. So you have a set of data, however, that set of data is not complete. If we have proper data sharing, if we have proper collaboration where the amount of data increases and the quality of the data increases, those kind of data, when you feed it into AI algorithms, that's when you get the better results. If you have bad data and you feed it into AI algorithms, the results are guaranteed to be inefficient. And if you have incomplete data and you feed it into the algorithms, the decision or the results or the insights are going to be incomplete. And the third part, or the third challenge, is the interventions. Again, AI is an emerging technology. When we talk about emerging technologies, they have one thing in common, and that is they advance so fast that legislations and policy making cannot keep up with them. So when we discuss AI, we hear terms like ethical AI, trustworthy AI. We have issues with AI that we did not anticipate. I can give you examples so they could apply them in health field or in other fields, but we have cases, for example, with self-driving cars. So a self-driving car is driving on the road and it gets in an accident. So who is to blame? Is it the car company? Is it the software company? Is it the developer himself? Is it the source of the data that used to train the AI algorithm? Or is it the driver? So these issues, the liability is an issue right now, and people, because AI is advancing so fast in a very short period of time, they are still exploring how to deal with it. The same thing if you can apply it in health field. What if an AI algorithm provided you with a diagnosis that was inaccurate? So who is to blame? Is it the doctor? Is it the AI? Is it the software company? And so on. And that's why it's important for policymakers to enable and help develop policies that will enable the AI algorithms or the AI as a technology to advance in a very safe way. That's why in Saudi Arabia, in the Digital Economy Task Force, one of the issues, or one of the major issues that we talked about is trustworthy AI. How can you utilize, how can you apply and deploy AI in a trustworthy manner, preserving privacy and preserving all other issues that are related to that. With that, ladies and gentlemen, I come to the end of my presentation. I hope I was able to provide some insights about how AI could help in the current and the future pandemics. Thank you very much.
Dr. Assam, thank you very much for your talk. Very interesting and thought-provoking. Let's move quickly on, however. It's my great pleasure to introduce you to our second speaker, to Professor David Bates. David is the Professor of Medicine at the Harvard Medical School in the US and Professor of Health Policy and Management at the Harvard T.H. Chan School of Public Health. He's also Medical Director of Clinical and Quality Analysis and Information Systems at Partners Healthcare and the Chief of the Division of General Medicine at the Brigham and Women's Hospital. David, before you start your presentation, maybe you can share with us what you do in the afternoons. Over to you.
Thank you so much, George. And it's a pleasure to be with you. Thanks to the organizers for putting on this terrific discussion. And I certainly enjoyed Dr. Assam's remarks. I'm going to talk about the use of artificial intelligence in weathering the COVID storm. And as a preamble, I'm going to argue that we did some things with artificial intelligence in this pandemic, but there's much more that we could do, as Dr. Assam suggested. So overall, there was a great variation among countries in terms of how they responded. And it's increasingly clear that how countries respond affects the clinical consequences, affects how many people are harmed, how many people died. Some countries, like Iran, initially tried to deny that anything was going on, and things went poorly there initially. Other countries like South Korea and Taiwan, for example, leveraged electronic tools to deal with the consequences and used contact tracing very effectively. I'm going to suggest that most of the COVID-19 forecasting models have used traditional epidemiological approaches, and that's worked well, but I think it's likely that we could do better in the future with AI. Machine learning has been used for things like outbreak detection, timely diagnosis, to predict death rates and rates of other complications. And finally, I'm going to make the point that there were major issues with data flow in this pandemic. And if we want to do better in the future, we have to do much better with data flow, and that would enable us to leverage AI in real time, which is where we want to get to. Dr. Assam mentioned Blue Dot, but I'm also going to talk about this. And they detected COVID-19 well before the World Health Organization. And their secret sauce was that they collect lots of information which are outside of official healthcare sources, like how the more than 4 billion travelers are moving on commercial flights annually. They collect data on human and animal and insect populations. They collect climate data, use local information from journalists and healthcare workers. And they look through nearly 100,000 online articles daily in 65 languages. So they're really looking at many different things. And that's a key thing about AI. Often you use data sources that are non-traditional. So what do you do if you need to control a novel infectious agent with unknown behavior, such as we were dealing with in this instance? Well, you need large quantities of data in near real time. And public health data in particular suffers typically from old infrastructure and lags in data collection and privacy concerns. In the US, many reports were being faxed in to public health centers. And this is something that we really need to work on going forward. In addition, in most developed countries, electronic health records are not routinely used as data sources by public health agencies. But in the future that we've heard about, they should be being used for better surveillance. There's all kinds of health information in there, which is very helpful. And finally, you need not just case counts and death rates, which is what we've had typically, but rich information about who gets the agent, who's at greater risk for it, and what the short and long-term consequences of acquiring it are, so that you can make intelligent decisions. We've argued that COVID-19 has really 4 important curves, and those of you who listened to Dr. Amalberti heard another version of this. We think most about the infectious disease curve, and that's the problems that the disease itself creates. But the issues of chronic disease and ignoring chronic disease are also really important. It's been shown in the US, for example, that the number of people who were turning up with heart attacks went down by over half during this pandemic. And we don't think that those people were not having heart attacks. We think that they were just staying at home and having them. And that is undoubtedly very risky. So this carries really very substantial risk to the population. There are also big issues with mental illness, things like depression and anxiety and social isolation. That's a very big issue as well. And finally, there are major inequities that have been exposed by COVID-19, things like unemployment and health disparities and social determinants. There are a number of constraints to use of AI, and you heard about some of these. Typically, the data are incomplete, and that can lead to uncertain or biased estimates. So for one example, the CDC reported that there were approximately 10 infections by their estimation for each reported case, and only the worst cases were being counted early on. It's also true that major disparities exist in the populations affected by COVID-19, and yet some of those inequalities are probably even underestimated because of the lack of racial, ethnic, and socioeconomic variables in our data sets. So we need to do better at gathering those. And then finally, sharing of data is difficult if agreements aren't already in place. And we did reasonably well with moving data around in this pandemic, but this was definitely a challenge. So how could we do better in terms of sharing data going forward? It's clearly critical to have better approaches, and there are a number of examples that were quite successful. One is the COVID-19 Decision Support Dashboard from the COVID-19 Healthcare Coalition. That includes over 900 healthcare organizations which agreed to share information about COVID-19. A second example, which is radiological, comes from the Radiological Society of North America, and they set up a COVID-19 data imaging repository so that you could look at large numbers of images and draw important insights from that. IBM set up something called their functional genomics platform, which enabled people to look at the genomics of this pandemic. And finally, the European Imaging COVID-19 AI initiative was supported by the European Society of Medical Imaging Informatics, and that's also been a useful resource. There's some other examples. One example of using artificial intelligence in real time comes from this organization called Clue, which basically set up tools to monitor patients who are in the ICU, and then using AI, warn providers of patients who were at risk. Here, there's one patient who's in the red zone. There's another patient who's in the green zone, and who could probably safely leave the intensive care unit. And tools like this, I think, will be very effective going forward in managing patients more effectively. And people have talked about how rapidly things were set up. This is a Sheba hospital in Israel, in which Clue, over a 2-week period, set up tools to monitor all the patients in this COVID unit, which was very rapidly set up. And the patients in this unit had very good outcomes, probably in part because of the AI that they were being monitored with. Another thing that's happened is we've developed a number of ways to visualize data, and it's critical to just have data at our fingertips and to visualize things better. This is from Worldometer, which probably many of you have looked at. It just looks at the cumulative number of cases of COVID by country, by number of days. And this was from August 4th. But we're all now used to looking at visualizations like this. They've been extremely valuable in making choices. So what about future pandemics? Well, I agree that it's essentially certain that future pandemics will occur. After all, we're a global society now. We move around. There are three critical steps, and those are prepare, respond, and recover. And I would suggest we actually have done reasonably well overall with the response part of things, and where we need to do better going forward are around the preparation and the recovery, which are in many ways harder. When nothing is going on, it's been hard for countries to invest in making sure that they're prepared. And in the U.S., we eliminated a number of the entities that were doing some of the best work in helping us be prepared just before this particular pandemic. Countries need to prepare and then maintain high quality public health data sets which can be shared. That is critical for policymakers to make decisions. You need also frameworks for sharing data between various entities like governments, health systems, industry, and academics. You need not just infectious disease data, but a wide array of data, as I discussed previously, and that has to address things like health equity and mental health and the chronic disease consequences. And then finally, you have to balance resource allocation between preparation and management and recovery. And here, too, I would suggest that we've really focused far too much on management and not enough really on preparation and recovery. So at the end of the day, I would suggest that keys to performing better in pandemics of the future will be able to predict what will happen. And also what the impact is of specific actions. There's so many actions that policymakers can take, things like closing borders or sending ventilators to specific areas. What about getting the population to wear masks? Or the one that we're dealing with now, what happens if you send children back to school? You need four things to really manage well. You need robust data. You need public health infrastructure. Collaborative networks are pivotal. And then you need appropriate policies. And the policies should be science and evidence-based. At the end of the day, I think artificial intelligence played an important role in this pandemic, but it will play a much more important role going forward. So I thought that polling question was a really good one. It will be a key enabler of better management in the next pandemics. And I will stop there. And I want to thank the audience and again the organizers.
Great, thank you very much, David. Sadly, we're not going to have any time for questions because of time restraints, but I just want to leave you with a few thoughts, thoughts that have been generated certainly in my head from the talks that we've heard from our two contributors. If we really want digital health and artificial intelligence to achieve its maximum potential, we need to do a number of things. We must embrace the principles of user-centered design and sound governance across all aspects of digital innovation, from the technology itself through to the service design, the business models, and of course, as we've just heard from David there, data. Data must be able to flow safely, securely, and seamlessly to where it's needed in a fully understood and consent-driven way. But we must also recognize, as we heard from Dr. Essam, there are other forces in play that must be addressed to secure adoption and scaling of digital solutions and the use of AI. And one of the key issues there is trust. Trust is an issue that shouldn't be ignored, be you an individual citizen or patient, a clinician or a politician. How we build and secure trust must be addressed and must be addressed now and delivered for us to maximize the benefits of any and all digital innovations now and in the future. And you, the audience, and I and my colleagues all have a responsibility to advocate for the use of digital tools and services in support of the delivery of not just sustainable ways of managing this pandemic and future pandemics, but the sustainability of health and care services in all countries around the world, which are under increasing challenges and pressures. But equally importantly, it's about sharing our knowledge and experiences to ensure we secure best value for any investment we make in artificial intelligence, machine learning, or any digital tool and service. And I'm not just talking about money, I'm talking about time and effort. And we must make sure that anything we do doesn't further inequalities and inequities that we have within our societies, but make things better for each and every one of us. Thank you very much for your time, and thank you to my two contributors.
Thank you all for such a great session about the role of artificial intelligence in fighting current and future pandemics. We're going to show now a video and we will prepare for our final session. Please stay tuned and we'll be back very shortly. Welcome back, everyone. Our final discussion of the evening will present the focal point of the summit, the Riyadh Declaration. To do so, it's my honor to introduce the Minister of Health, is His Excellency Dr. Tawfiq Al-Rabia. Tafadhal Malik.
Thank you. Bismillah ar-Rahman ar-Rahim. Your Excellencies and distinguished guests, I am honored to be with you today at the Riyadh Global Digital Health Summit, organized by the Ministry of National Guard, Health Affairs, and hosted by the Kingdom of Saudi Arabia as one of its G20 presidency associated events, and in collaboration with the Saudi Center for International Strategic Partnerships. During the Kingdom's presidency of the G20 and prior to the emergence of the pandemic, we have introduced pandemic preparedness and digital health as key health priorities. The emphasis on digital health was critical as it plays a fundamental role in supporting health emergency management by strengthening existing response mechanisms. Digital tools also enable innovative, equitable access to health services, data sharing, and improve coordination. We in the Kingdom have capitalized on many of our existing digital applications that offer AI components in tackling this pandemic, some of which include the central appointment system, Maw'id, which is an app that enables patients to book appointments with their doctors at primary healthcare centers, as well as managing their referral appointments. Total appointments that has been done so far in the past 2 years exceeding 50 million appointments. We also established a virtual medical consultation app, Saha, with an AI component that offers face-to-face interaction with medical professionals and can be used abroad by Saudi citizens and residents at no cost. We have also established drive-through testing capabilities, which can be booked electronically to enable individuals to conduct COVID-19 tests from their vehicles on the day of their choosing for their convenience. We have also developed a dedicated app, Tatamman, for individuals in isolation facilities, which provides direct and continuous contact with the patients to provide them with up-to-date health case information, as well to ensure their compliance with health regulations. We have also concentrated our efforts on safeguarding our healthcare practitioners by developing dedicated apps which allows them to share medical information and prescribe medications to patients remotely with no physical interactions to minimize the possibility of infection. We have also implemented virtual clinics and tele-ICU, which provides healthcare practitioners direct access to patients remotely. This has allowed for seamless communications with residents and nurses to consult virtually. Tele-rounds and remote consultations were also made possible through robotics, which safeguards healthcare professionals by minimizing physicians to COVID-19 patients' contact. Teleradiology has been expanded to cover COVID-19 designated hospitals, and medical protocols and guidelines are published online and are available via an app to ensure dissemination of information in a timely manner. These digital tools, along with the implementation of exceptional health and safety measures, have assisted us in successfully navigating what is typically one of the largest religious gatherings in the world under extraordinary circumstances. Pilgrims arriving in the holy cities were electronically tagged with bracelets designed to monitor and record their health status and track individuals quarantined upon their return home through the Tatamman app. And as a result, we have been very fortunate to have 0 cases of COVID-19 during Hajj this year. These initiatives prove that digital health has and will continue to be the most effective tool in which we can ensure rapid response and delivery of efficient, safe, and effective care. The collaborative efforts exerted by all participants are showcased in the success of this momentous event and by the announcement of the Riyadh Digital Health Declaration, which leverages the role of digital technologies and innovations in our fight against COVID-19. And with that, please allow me to introduce His Excellency, Dr. Bandar Al-Ganawi, the CEO of the Ministry of National Guard Health Affairs. Thank you.
Good afternoon, everyone. We're again here today after a remarkable event over the last 2 days. It's been an achievement for everyone, trying to really link everyone around the world to this major event and health summit related to digital health. It's truly been a wonderful experience, exceptionally remarkable that we see how many people have been really connected around the globe to really view this from Riyadh, Saudi Arabia. With this, I would like to thank, on behalf of you, His Excellency Dr. Tawfiq Rabia, the Minister of Health Saudi Arabia, for chairing the final session of the summit. On behalf of the organizing committee, we appreciate his support and leadership, and it is indeed an honor to have Your Excellency today for this final event. We're really overwhelmed with the level of enthusiasm across the globe, as over 135,000 participants registered virtually in this important event, and more than 300 non-registered viewers over multiple social media channels has really watched this event. This is truly remarkable. This is really one of the largest virtual events that we ever witnessed. The strong interest is a reflection of a high caliber faculty, advisory board, and a comprehensive program, as well as the timeliness and relevance of these topics that we have discussed in this summit. It also reflects the global reach demonstrated by the Kingdom of Saudi Arabia in its assumption of the G20 Presidency 2020. Indeed, it was evidenced by this summit how technology can connect the global scientific community in an extraordinary way. So we really achieved this through technology, that all of specifically the health scientific community around the globe has been connected. This link is so essential to succeed in implementing evidence-based innovations to protect humanity from the danger of pandemics. We're really privileged to hear from all speakers, chairs, and co-chairs of the session some of their amazing achievements and excellent initiatives across the different disciplines. The active participation of the attendee is remarkable and has enriched our understanding, as well as opened, in some instances, really new horizons. We will exert every effort to have a connected world through digital health in fighting current and future pandemics. I would like to thank every one of you for this invaluable contribution in making this summit an event to be remembered. I will move on to really present the final recommendations, what we have labeled as Riyadh Declaration, the role of the digital health in fighting current and future pandemics. I'm really pleased to be working over the last few weeks. We had more than 7 to 10 panel meetings with members from around the world. I'm pleased to present the names of the people who have really participated with us in Saudi Arabia, with the organizing committee chaired by myself. I would like to start with Professor Mahmoud Adel, Professor David Bates, Professor George Crooks, Professor Tom Dunwood, Dr. Hani Jokhdar, Professor Michael Kidd, Professor Michael Clegg, Professor Olshin Lee, Dr. Ali Mcdad, Professor Kayara Poletto, Dr. Curie, and last but not least, Louise Chapper. As well, the team here in Saudi Arabia, myself, Dr. Ali Katami, Dr. Raid Al-Hazmi, and Dr. Jude Abdul Jawad. With the key priorities that we have worked around over the last, as I said, few meetings, looking at crisis and risk communication, health data governance, quality, policy, and regulation, and it is really implementable use in practice. Established health intelligence, adoption of interoperable digital technology, scalability, and sustainability. Enhance the quality and effectiveness of digital technology for improved patient and population outcomes. And more importantly, I think research and innovation, which we have witnessed during this crisis and pandemic, that really evolved around technology, that we really moved forward ahead, and we should really, all of us, share these different, really learned lessons, really admirable outcomes for research and innovation. And what we mean by this is applied research and applied innovation. Few core principles has been adopted during our discussion. Inequalities in digital health capabilities and access are experienced at an individual, local, national, and global levels. We should strive to decrease inequities, and embrace digital inclusion. Digital health should enable and empower people, as well as health and care systems, to prevent and treat communicable and non-communicable all diseases, to sustain wellness. Real-time access to high-quality data is essential to provide accurate, science-based information, develop policy, promote health, deliver health and care, support efficient and effective public health measures, to foster rapid research and actionable outcomes. Use up-to-date and trusted information is necessary for individuals to exercise their responsibility to follow public health recommendations during a pandemic. Collaboration between public and private institutions, research and innovation should be prioritized during pandemics and promote access to data. I think this is very important. Digital health must preserve the fundamental rights of privacy and consent. We wanted to conclude our core principles by really somehow a definition of what we used as health system, include all public, private, academic organizations that provide health and care. Recommendations has been really reviewed a few times, and I'm pleased to announce them. Number one is effectively implement data-driven and evidence-based protocols for clear and effective communication with common messaging in order to build citizens' trust. Work with global stakeholders to confront mis and disinformation propagation through social media platforms and mass media. Establish standard global minimal data sets for public health data reporting, as well as data governance structure tailored specifically to communicable diseases. Ensure countries have established priority in relation to data and digital health, in particular, digital maturity and infrastructure. Enable health and care organizations with the necessary technology to transform high quality, timely data collection and sharing for applied health intelligence. Cultivate a health and care workforce with the knowledge, skills, and training in data and technologies. Data and technologies has to be always shared, that we really have to be really prepared as healthcare workforce to be able to have the basic skills and, of course, upskilling of these skills. Required to face current and future public health challenges. Ensuring surveillance system combine an effective public health response with respect to ethical and privacy principles. Develop digital personal tools and services to support comprehensive health programs. We mean by that disease prevention, testing, management, and vaccination program globally. Last but not least, and more important, to maintain, continue, and fund. Maintain, continue to fund and innovate surveillance data systems as a core part of the connected global health system for rapid preparedness and optimal global response. This declaration is a call to action to create the infrastructure to share good digital health evidence-based practices and real-time high-quality data that encompasses local and global level to enable more health systems and countries to have an actionable insights. Digital and data technology will promote the coordinated development of shared global public health policies and resilient health and care systems. This is in order to specifically perform better in future pandemic and other health challenges. Thank you very much.
Thank you, Your Excellencies, and congratulations on the success of this summit. As we close our final session, I'd like to thank you all for your presence, engagement, and participation. Over the course of the past 2 days, this event brought together incredible speakers and leaders on the topics of healthcare systems, public health, digital health, academic institutions, and businesses, in order to discuss the vital role of digital health in the fight against current and future pandemics. It was a pleasure to hear your expert insights and experiences. Thank you for your time and effort. Best regards from me, Wearable.